Association for the Advancement of Blood and Biotherapies, US Oncology Services, London, UK. She received the AABB President's Award recipient for Cell Therapies Biotherapies 2022. She has 20 plus years of global leadership experience in managing and operating diagnostic and reference lab. Next, Dr. Debolina Ghosh. She is a consultant in pain and palliative care at R.N. Tagore Hospital. The session will be moderated by Dr. Swati Bhatt. Over to you, ma'am. The speakers for this panel discussion include Dr. Gautam Das, sir. Dr. Gautam Das, sir, is the founder of Daradia, the Pain Clinic, and ex-dean of Indian Academy of Pain Ultrasound. His area of interest includes MSK ultrasound. Next is Dr. Ashok Kumar Kadam, sir. He is a consultant orthopedic surgeon and diplomat, board certified from American Academy of Regenerative Medicine with 24 years of experience in orthopedics. Next we have Dr. G.K. Kumar, sir. From FNB from Chennai. Dr. Preeti Doshi, ma'am. She is Director Pain Medicine at Jaslok Hospital and Research Center, Mumbai. Program Head for Pain Fellowship at JHRC. Honorable Secretary, the Neuromodulation Society, and faculty on board for EEPI and PGCC course on neuromodulation. Next we have Dr. Namrata Dabas. She is the Principal Consultant Pain and Palliative Care at Max Super Specialty Hospital, Dwarka, New Delhi. Over to moderator, ma'am, Dr. Swati Bhatt, ma'am, please take over.
Welcome the chairpersons and dignitaries on stage, my panelists. I would request all the audience also to gather for the panel discussion as soon as possible as you finish your lunch. So we will delve into another important topic which we see in our clinical practice, though not very common, but a very important aspect. Avascular necrosis of the hip. It's a significant condition that can lead to joint degenerations if not addressed properly. Early diagnosis and appropriate management are essential for preserving the hip function and improving the quality of life for these patients. Nevertheless, if the diagnosis and management is not followed well in time, it can deteriorate a patient and the patient can lose the quality of life at a very, very early onset. I would straight away, we are having very less of time, so I would straight away delve into the questions with the panelists. My first panelist, I think I start with Namrata, who's with me. Namrata, I would like you to take us through the clinical presentation and pick up such patients. How do we pick up such patients in our clinical practice?
Thank you, Sati. Okay, avascular necrosis of hip, basically patients are usually young patients in the age group of 20 to 40. And many a times, patients basically will come with a pain in the hip, in the groin region, referred to the back. In the early stages, pain will be on and off types. In the later stages, although the patient might present with a limping, difficulty on putting weight on that limb, there will be associated stiffness in that region. Later stages, the patient will also complain of night pain and morning stiffness, obviously associated with that lot of inflammation ongoing in that area. And basically in the history part, we need to exclude because there are some risk factors which are associated with the avascular necrosis of the hip. Use of corticosteroids is a very important risk factor which has been associated with the AVN of the hip. in the recent time we have seen that increase in the cases of the AVN hip, most probably after the COVID-19 wave, because of the use of, rampant use of steroids in those patients. Alcohol, history of alcohol intake, that also increases the risk of AVN hip. There are some coagulation disorders, like sickle cell anemia, hemophilia in all those patients. There might be some infarcts in the blood supply in the head of the femur that might cause the AVN hip. So in the history, we need to exclude these causes. In the differential diagnosis, obviously, we need to rule out, because patient with the septic arthritis of the hip may also present with that features of the pain in the that region in the hip and with the limping. So that's a sort of red flag, because we need to rule out septic arthritis of the hip or TB in the hip. And I think that's how we go about the history and the diagnosis. In the examination, yes, there'll be decrease in the range of motion in the hip. There'll be tenderness in the hip region, in the groin region. Patient will complain of pain in that area. There'll be restriction in all the range of movements of the hip, including the abduction, adduction, internal rotation. All those examination we need to do to rule out this. And I think, yes, that's how we can come to a conclusion that patient might be suffering from some hip pathology. But yes, we need to investigate. The early cases of the AVN hip might not be picked up with a X-ray of the hip joint. Okay, so I think investigation part will be taken up by some other my colleagues.
Yeah, so I think to summarize it all, it's very important to remember that this also is one of the very important causes when we are looking at somebody who comes with a hip pain or low back pain with some restricted movements majorly. So we need to keep it at the back of our mind, and it's a young patient we are dealing with all these risks.
Yes, it's not only the osteoarthritis hip,
correct.
That AVN hip should be kept in mind while
it should always
investigation.
be kept in the mind. Also, another group of patients I've seen this happening with is the those patients who have had malignancy in the past and have been
History of the radiation, the radiotherapy and all, because that also causes that the blood supply in that region is restricted because of that, affected
so
because
I think
of
we
that.
need to keep our differential diagnosis always in the mind. Dr. Preeti, how do you think we should go about evaluating these patients, that we go end and figure out what is wrong with these?
Sure. So as Namrata described, of course, the clinical presentation is very important, and it is a slightly different age group than the osteoarthritis, when it will present. So this is more common in younger age group, more common in 20 to 40 age group. You also see it more in male patients. So whenever you have such a patient who's complaining of pain in the region of the hip, you will have a high degree of suspicion, and you would like to investigate them, because many a times I have seen young patients coming with this, with severe pain in the groin. They have no other ailment, nothing, and they just suddenly present with severe pain. And this is one thing which you have to keep at the back of your mind to investigate. So as she says, X-ray, yes, but more I think useful maybe a CT scan or an MRI scan, which will show the typical features of avascular necrosis in terms of the vascularity. And there is a classical crescent-shaped shadow many a times which is found in the femoral head. There may be a secondary osteoarthritis also, and also there is a classification by which you can also identify what stage of AVN this particular patient is. And also it's very important to find out what all treatment the patient has been subjected to so far, and then we can consider, further management.
So I think the gold standard happens to be MRI, and followed by a little more investigation can be done in the categorization for CT. of course, in our country, we have to remember when we've already
Uh,
subjected a patient to
yes.
MRI, whether they would want to go with the CT or not. But still, MRI, we have to always keep it.
Another thing which I think we have to keep in mind is the differential diagnosis of a pain arising from spine. So we do need to examine the patient also thoroughly from that point
the
of
other
view.
causes of pain,
And yeah, so to rule out that it's not
rheumatoid, etc. We
it's
need to
not
do all the systemic
inflammatory
tests,
arthritis, etc. So we may need to do some blood work also to try and
Evaluate
kind
and
of
rule out the other
identify
causes.
those issues as well. Yeah.
Right, ma'am. I think we know about the investigations of choice and how to rule out the other causes of inflammatory markers and everything. So at the onset, I would really want to go a little bit more into why at all do we develop this and what is the etiopathogenesis of the disease. So, Dr. GK, would you want to?
Yeah, depending on the etiopathogenesis, the main cause is the name itself clearly states as the osteonecrosis of the head. So the something is necrosis, it is real to vascular cause. So some of the vascularity may be compromised. Patient may go for tissue necrosis. All the things will come, and that is the reason for that. The head of the femur is mainly supplied with the obturator and femoral artery, and if there is anything happens due to that, compromise on that, definitely it goes for vascular necrosis. The prime suspect is the sickle cell anemia. Some of the diseases may cause bilateral trauma is the another leading cause, and another thing is the drug which would have been caused after the post-COVID. If the patient comes with you pain in the back, you don't think it is always arising from the spine. It may be the local cause, especially a patient with restricted movements are there. So never ever forget to take the simple X-ray or include your MRI study into the pelvic area also that. So many cases, the young cases nowadays are coming with the AVN after the post-COVID thing, because the steroid was, steroid was widely used all around the world. That's a common cause. The drug will be the another common cause for that.
Dr. Kadam, you would like to add anything on more to it?
It's important to take history. Sometimes the patient, they have the knee pain. They don't have hip pain.
Oh.
So then the referred pain, they have pathology in the hip, but they are coming to you in the knee pain. So if a young patient below 30 coming with the knee pain, no injury, you should also see on X-ray to rule out this. And also in young patient, we need to take history of any developmental dysplasia of the hip. Like during childhood, was there any brace history, or was there any walking issue? Because that's also one of the reasons for development DDH and leading to the AVN.
I do see a lot of, as I was going through the research on various papers that have been published, there's some amount of classifications different groups have been giving. So can we follow those as per se?
In general, if you see, combine all these classifications, so basically in stage 1 is doubtful. So patient may have mild clinical symptom, joint pain, but X-ray is normal. And you have tried many things, still they have morning stiffness, limited abduction and internal rotation. Then it's good idea to do MRI or the bone scan. Because sometimes even the MRI take a little bit longer than the bone scan.
Yeah, so these classifications do not corroborate with exactly with the
Yes.
stratification
yeah.
or the category which they come into.
Yes.
But there are different categories. There's a Japanese.
They are like ARCO classification, but they are basically dividing into 4 stages.
Yes.
So last stage is when you have evidence of osteoarthritis on X-ray. Then the stage 3 is when there is a collapse. So you see the head is deformed, collapse is there, and early osteoarthritis is there. Stage 2 when there is a subchondral fracture which may or may not be there. And stage 1 is the suspicious. So there is also whether the subchondral collapse, sometime some classifications say it will belong to stage 3 rather than to stage 2. But for a broader perspective, it is pre-collapse and post-collapse.
Right.
So if it is post-collapse, then the indication is different, surgery, and pre-collapse, then you have these conservative options.
So I think since you have already touched upon a little bit on that, my next question to you was, how do we, I mean, if you would give us a bird's eye view of how do we manage these patients based on the same that you
Sometime when you see the, like suppose it's stage 1, X-ray is normal and MRI shows there is a edema is there. You just see the bone marrow edema. There is no necrotic area. So in those patients, we should not jump to core decompression. So it's better to try like crutch walking and keep under observation for 6 months. After 6 months, if the MRI shows that there is no progression to the necrosis, you can continue the same. But if there is a necrosis is there and collapse is not there, then you go for conservative treatment. So for surgery wise, if we see the commonest and the oldest is the core decompression. So there is a theory that AVN happen because inside the head there is an increased intra-osseous pressure. So when you make a hole for this, the neck and the head, you are releasing the tension. So for decades this was the only treatment. But later on it was realized that when you are making a hole, there is no structural support. So then we started using the bone graft. So initially it was from the ileum, the autogenous corticocancellous bone graft. Then it was realized that after some time in some patient, there is a resorption of the graft. So again that support is not there. So then came the role of vascularized bone graft with fibula or non-vascularized. So when you take a fibula piece of a bone and put in that hole, it gives some support. But it was in some patients the disease still progressed. So then we use vascularized bone graft. And now because of the regenerative thing, if you can ask, then I can elaborate later.
Yeah, I'll add on to that. So I think that's a good bird's eye view of how we categorize these patients. So what is most important is whether it is a collapse or we are dealing with somebody who's not yet gone into that stage, and how can we really avoid doing a surgery in this patient and stabilize his life as best possible and avoid all these complications. So I think that would be a good standpoint to figure out. And again, early diagnosis is the key to the success of any treatment in this. Nevertheless, these patients, when they come to, that would be mostly when they are coming to the surgeon. We as pain physicians, when we deal with these patients, they are a havoc because they have tremendous amount of pain. So how do we deal with that? I think Dr. Gautam Das would be the best person to tell us about it. Of course, everybody else will join in.
So first I'll be emphasizing the diagnosis again before going to my question what you have asked me. Because just last week, and this was not the one, in my practicing life, I have came across with almost more than 10 such patients. So just imagine what will be the coming in our mind first if I'm giving you this history. That suppose somebody is about the mid-30s or 40s, a male patient complaining of the buttock pain radiating down to the back of the thigh, up to the knee. Patient is comfortable on lying down, standing is having pain, walking having pain, and SLR, if you are lifting the leg, patient is having pain and not allowing to do the SLR. Do an MRI and multiple bulge, so you fix that, okay, problem is in the disc. So this case, last week what I felt was, those who are from the Calcutta, they know this neurosurgeon very much, very famous neurosurgeon, and I'll not be telling the name. But this patient was telling that I am suffering from the last 6 months, and I was given gabapentin. The exactly history what I told you, but this is not the only one case what I was going to tell. That this was the at least 10 such cases in my practicing life I have came across. That means the pain physicians and neurosurgeons, not much of orthopedic surgeons, they miss this avascular necrosis very much. So, and very important part is, if we are going into the grades, particularly the stage 1, the range of movement of the hip might be completely normal. So that might not be able to make a diagnosis that hip might be the pathology. So what is important is we have to include this in our differential diagnosis, and just not looking about the disc bulge, because that is one of the very common findings. Almost 50% of anybody at around 40-50s will be having the disc bulge, should not be fixing the diagnosis. So this is what I want to tell. And now coming to the treatment part, Most of my experience, what I have felt, the patients where the patient was having the stage 3 or stage 4. Stage 3 and stage 4, mostly this patient ultimately have to go with the now or later, they have to go for the total hip replacement. The avoidance of the hip replacement is possible only when we are making a diagnosis in the stage 1 and stage 2. When there is, no hip is completely, there is, no flattening of the head, no joint space compromise. So in these situations only, what Dr. Ashok Kumar told about the decompression, and I was searching the recent literatures because my experience with the BMAC, other stem cell therapy is very limited. I'm not doing it. So I was just searching about what are the current evidences. And I clearly found that there are a few studies which are comparing these three type, means either core decompression alone, or the regeneration therapy alone, or combination.
Combine.
So this was telling that the only regeneration therapy, if we are seeing the patient in the stage 1 and stage 2, chances of preventing the hip replacement is less than 50%. That means result is not that good. Only the regenerative therapy in stage 1 and 2. Only core decompression, success rate is slightly better than the regeneration therapy, slightly something around 60-70%. Exactly, I don't remember the percentage. And the best result of avoiding the hip replacement in the stage 1 and 2 is if we are combining these together. So this was, but unfortunately, as I told you, if you are asking my experience about this, I have done few cases of the PRP, but most of my cases what I faced is, stage 3 and stage 4, where we really cannot avoid the hip replacement. What you can do is you can delay the hip replacement by limiting the pain, so there we are having the two options there. The best options, and my most experience with that is the cool radio frequency ablation of the articular branch of the hip. So there we do with the femoral articular branch and accessory obturator and obturator now, and results are quite satisfactory. And on an average, patient gives a pendulum of around 1.5 years, 1 to 2 years is the average duration of the pendulum. It can be repeated. But again, this is not going to prevent the hip replacement. This is basically delaying for some reasons, or if the patient is too early age, 30s, so they don't want really the replacement. These are the things. And sometimes in few cases I have done only PRP, results are also not bad, at least in dealing with the pain for some time, 6 months pain relief is, particularly the PRP with the hyaluronic acid together, give a significant amount the pain relief in this kind of patients. But again, that should not be the treatment of choice, as I told you. As per the evidence-based literature is telling, the combination of these two together is the best. For grade 3 and grade 4, again, my choice is the articular branch ablation of this.
So I think pain management would be cooled radio frequency of the joint.
Cooled radio frequency is the choice, and 3 nerves as our target: articular branch of the femoral, articular branch of the obturator, and accessory obturator.
That would give the best relief for such patients, and it would be long lasting also. By the time the effect of the regenerative therapy takes place, I think 1.5 years, at least if the patient gets that kind of a relief, that would be a good standpoint at that. Ma'am, would you like to add anything more, your experience with these?
Yeah, so I think whatever Dr. Das said, it's all acceptable, and that is how we generally, even I deal with in the same manner. But I think what is more important is also a close monitoring of these patients, even after doing our therapies like radio frequency or regenerative
That's
therapy.
very important.
We need to follow up these patients closely and also explain them that there is a chance of progression. So in case if they progress, then we have to have a, we have to be vigilant to intervene, because these are young patients in their productive phase of the life, and we want to give them a good quality of life. So generally they may become more symptomatic and they may come back, but if not, at least I think you need to keep a close watch and try and identify, them progressing into
So
a...
how do we prognosticate, or how do we keep assessing them? Is it the MRIs, successive MRIs, and how frequently?
So it's either the symptoms coming back or the changes in form of MRI, I think.
So how
So we can
frequently
keep
do
a...
we repeat them, either a yearly or a 6-monthly MRI?
So I mean, it will all be subjective, but generally 6 months or 1 year would be a good time frame, yeah.
There's this one.
Yeah, sorry, can I add something to the general
Yeah, please,
discussion? Sorry, I couldn't just stay at the background. I feel whenever we are talking about avian or any degenerative process, the first question should always be a standard CBC, standard blood count, standard testing, which we have forgotten, and the art of history taking, because the patient itself will tell. Most of the avian out on the public as well, I'm going to ask, how many of your patients give you a history of fall or injury during school, college, any of these? That's your starting point. Second is active life, sedentary life. Third, obviously, a lot of people have a lot of inflammatory process already. So CRP, all inflammatory markers basically. I was very happy to see GK's slide today talking about diet, talking about, the whole exercise. And exercise doesn't really mean active, but a lot of avian has been an epidemic now. So we have to look at what we are going to do. And yes, few of you might feel that, no, but that's my bread and butter, which is okay. But at the end of the day, if you're going to have a successful patient, he'll still come for regenerative, definitely. So there are a lot of ways and means that we can look into avian, because before it starts till there, I mean grade 1 and 2, there are a lot of things which your patient is going to tell, and that is when you have to catch your patient, whether it's orthopedics, whether it's pain, you have to look into that, definitely. Second is creating education and awareness around it, because I think Dr. Preeti also answered very well about how it is, because definitely how many patients can really do MRI every year, especially in the Indian setup or low economic. Even if I'm in Dubai and I tell everybody, go and get an MRI,
Every 6 months,
insurance
anybody
doesn't
hardly would
really cover,
agree.
so there's a lot of insurance approvals which are at stake as well. So I think overall, when we talk about any, plus is there any metabolic? So we are now also doing microbiome testing for our patients, because most of the time it's the gut, that gut axis with the inflammatory has led to, today he might present with avian, or tomorrow he might present with something else along with that. So unless and until you will not treat, that's why my slide was, don't just treat the symptom, go and see what is happening behind that. So, that's what I just wanted to stress here. I know I might be controversial because of clinical path giving this, but 22 years of my life I've been doing regenerative. So I just want to put that into perspective. Thank you. Thank you, sir.
Just one question to Ashok. In terms of decision making, what I heard from my orthopedic colleagues, quite senior orthopedic colleagues in my area, they started saying that they've not been doing the core decompression. They stopped doing it recently after getting all the negative data from it. And they say straight, if the patient is actually going progressing the disease, just go for a TPR. If not, just leave them on analgesics as long as you can. They've not been doing any other regenerative therapies, nothing, this or that. So where would you stand, and what would be the logic behind it?
See, generally speaking, as a joint replacement surgeon, we don't want to change a hip any patient who is below 45. The reason is, when you do total knee, it lasts for 20 to 25 years. But when you do a total hip, it lasts for 15 years. And if the surgeon is not experienced, 10 years. So every 10 years he is going another hip. And every time you are causing more bone loss, and you are using more expensive prosthesis. Now, as per your question, you are saying, no, that's not the practice. So in core decompression, we combine core decompression with a fibular bone graft, which is a non-vascularized. Because only very few surgeons, they can do vascularized bone grafting. So if a patient is like say 30 and has AVN, we should go, and he's pre-collapse. So the practice is do core decompression with a fibular graft. That will last for like another say 5 year, 10 year. And once he is beyond 45, then we want to do total hip. But if a patient is having a painful stiff hip, no movement at all, then total hip should be done. Because there's the prime life, he has no movement. He can't sit on the chair, he can't do cycling, routine activity. That's the thing.
Yeah, I think that summarizes it and makes sense. We need to progress. I mean, we need to
And
lengthen
also,
the period of time as best as possible.
and if there are two scenarios also, like pre-collapse and post-collapse. Somebody has like pre-collapse and he is not willing for core decompression, or core decompression has been done but it's still painful. So once you do MRI, you will see there will be synovitis inside the joint, effusion and capsulitis, and there's the reason of the pain. In each patient, if you inject PRP with or without hyaluronic acid, they will be good for at least 1 year.
Yes.
So many patients, they come annually. If a patient is post-collapse, but he is not like he is 35 or below 45, they can't just go with
Go on.
painkiller. So you can again do these treatment, PRP or your pain management, it helps them.
Yeah. So, sir, I want to ask that, like Gautam sir has told that we are doing avascular in avascular AVN. So we are doing radio frequency ablation of the 3 nerves, reticular branches, and all. So we are also having this kind of patients, and after 1 year again we have to repeat because these are the young patients and the replacement. So Gautam sir, you are doing PRP. So maybe it is going to help the patient after till 1 year, or
That
so
is what he
should
was telling.
should it be repeated like?
Yes, what he was telling, that replacement surgery should not be done in the early because of these limitations. So suppose somebody is in the early 40s, late 30s, this is the common age group, around 40. So that is not the ideal age for the hip replacement. So if you can defer with the pain relief, if you can defer this hip replacement by another 5 years, so that is good for the patient. So that is our aim. That we can do the radio frequency, or that you can do the PRP or the HISCO, the what I told, even BMAC or the FAT can be the other alternative, but I don't have any experience. But what experience I am having, the hyaluronic acid plus PRP, they can give a good pain relief of around 1 year. So you can repeat it after 1 year.
Single injection for
Single
1 year.
injection.
Okay.
Single
That is-
injection.
That is why.
The PRP? Well, if you are doing under sedation, better to go both. So in that case, intra-articular and intraosseous in the subchondral region of acetabulum also, because there will be some sclerosis, and in the head also. Then only head, and with intra-articular.
So
Microneedling. Yeah, that's microneedling. What you're saying? Decompression.
It also depends upon the quality of the necrotic bone. So suppose if the necrotic bone is soft, so in that case it's fine that you can do this minimal anterior. But if it is a hard sclerotic bone, then we need to remove that necrotic bone and fill the fresh autologous corticocancellous bone graft with or without any regenerative, whatever you have. That's what. That's. No, that's what I am saying. The pain is not just because of necrosis, capsulitis, synovitis. When you're doing fenestration, intraosseous. Yeah, it will help. Yeah, yeah. Because it will reduce the pressure.
Essentially, when there is a collapse happening, your cartilage will be damaged in majority of cases, even on the head. When the cartilage is damaged, and then you also would have the roughened bone, the head, which is actually obstructing or maybe roughening of the acetabular cartilage. Both of them would be happening. So, how much of the necrotic tissue will stay under the cartilage? It's actually open up, and even
like being at AIMS, we have seen referral patient, they come from the rural. So everybody wants to get treatment in the AIMS. So in many of those patients, they have like stage 3, stage 4 with subluxation, mild subluxation, and they are not so painful. They come for instability. That's what I am saying, that the loss of cartilage is not the only indication for the joint replacement. They are managing for years. They are so what they do, somebody suggests them like shoe raise just to manage the height and balance the pelvis. So it depends patient to patient.
So like we've been talking and we've been listening to so many lectures since morning. So how do we classify or how do we summarize these cell-based treatments for core decompression?
So basically,
What all can we do exactly?
so in my practice and whatever the standard regenerative procedure are, we do core decompression, remove the dead bone out, fill the defect in the head and the neck with a autologous corticocancellous bone graft, and that graft we mix it, whatever you have, if you have PRP, if you have BMAC, if you have expanded stem cells, so we mix everything and then we fill that, it's like a impact bone grafting. So we are pushing these bone graft up to the head, up to the subchondral lesion, and the problem comes when you just inject the stem cell or PRP, at backflow. So we make sure that when you have done the core decompression, that hole has to be plugged back. Otherwise, whatever you are putting, it will come back. So that done in different way. Either we take like a biomaterial, like tricalcium phosphate, which is a biodegradable material. It's like a putty, and we put it. Sometimes we make a small window and put it back. Sometimes we take the fat. If you're using fat, then you can put it there.
We know that there are BMAC definitely
Can I
has.
just add something to what Ashok said? You could also do PRF, which can be very easily available for all of you, and it's at no extra cost. So if you don't have a biocomposite material, use a PRP. So when you're opening a small window or making a punch, better to put PRF and then add these cells, so they will stay in the area for a longer time and help in regeneration. So that's another thing.
So we know that BMAC has a lot of advantages when we are doing with this and chondrocyte positive and all that. We know about it. Any disadvantages or adverse effects associated that we need to be very careful?
No, I think it is the quality of the bone marrow concentrate, because there is in some patient like they have sickle cell anemia and steroid. So when you are taking the bone marrow, it's very difficult. It's totally dry tap. So that's one disadvantage of BMAC if in these particular patient. Then second thing, the quality of the bone marrow BMAC should be good. So better to take from the posterior side, posterior iliac crest, because the quality will be good, yield will be more. And I don't think there is any disadvantage if you use BMAC for these procedure. There is no disadvantage. Basically, we are not just relying the stem cell when you are using the bone marrow concentrate, because number will be very less. We are also relying on the BMP. So we have bone morphogenetic proteins and growth factor. So of course with the age the quality will be less, but in that case you can combine some other biomaterial just to act as a temporary filler until the healing happens.
Okay. So, sir, are there any challenges to the cell-based procedure outcomes?
You're asking me?
Yeah.
No, basically if you see the literature, it's quite variable. So some literature will say if you use stage 3, stage 4, it works in 60% of the patient when you are combining bone decompression with stem cell, either BMAC or the culture expanded. But in stage 2 and 3, the result are 90%. So it's variable. And of course it's expensive also. And sometime regeneration or revascularization will not happen. What these stem cell degenerative are doing, they are just preventing the further collapse. The shape, whatever is there, it maintain, and patient is able to pass 5 year, 10 year, and once they are above 45 and osteoarthritis, they can go for joint replacement.
Yeah. So at least we are differing the.
Yeah, it's like delaying the requirement of total hip.
So, Dr. Das, would you add anything on the challenges? Okay.
So what I understand is the ultimately 1 and 2 is the area where the prevention of the TKR, total hip replacement is possible. But again, only this therapy, regeneration therapy, has the limited value compared to that of the combination what he was telling, means decompression plus the other therapies. And as I told, I don't have any experience over that.
So, are there any protocols presently? Let's talk about our country first. Do we follow any protocol? Do we have a protocol as such, or to deal with the legality? I know exactly there are lots of procedures we are doing nowadays, whether it is pain, interventional pain or regenerative. We do not very 100%ly follow all legalities, but we need to know where to draw the line. So, what is strictly a no? So, do we have any guideline like that, or can we have some framework as to what is the bottom line?
Well, for that, she is the expert. I can only talk about as an orthopedic surgeon. There is no bar if you are using bone marrow concentrate with co-decompression. So minimal manipulation, I think, and she can answer this question better.
So we'll come to both of you. I want to have a consensus on this. Yeah.
So I think until and unless you are not doing any more than minimal manipulation, you can use any regenerative product with co-decompression.
That is what is. Yeah, correct. Correct. Yeah, so physicians are exempt from the usual regulatory lingo because it's a same-day procedure, and inside OT you are doing a major procedure which you have already received training for. So there's no regulatory oversight required for that end. This is why when you're doing, whether it's a BMAC or even adipose is also when you're doing minimal manipulation, but anything beyond that, the moment there's enzyme or expansion, so cell expansion, that's more than minimally manipulated. That's where the regulatory oversight is. But most of the times nowadays, you can do PRP, PRF, BMAX, adipose, microfat, nanofat, you can still do that other than, all of this. And this will be
there's a lot of
procedure.
there's a lot of fear when we are.
I'll just, thank you, because that's a good question. You are in trouble when you have not checked what kits you are used. Are they approved by your regulators? That's one. Second, are you labeling these correctly? So most of the time it's one patient in one OT, so that is another thing. So labeling and misidentification is the other cause where regulators have question. And third thing is, whenever anything leaves out of the OT or out of your procedure room, that's another thing which is of concern. So as far as you've taken care of all of these things, and even going back to take proper informed consent, because not like I approve and I give consent for anything and everything. No, that doesn't work. So you have to take a proper informed consent, starts from there. And these three things, if you take care of, your practice is good. So don't need to, panic or have that, but have systems in place which are there, so you are safeguarded at all time. And sorry, last is the documentation part. So keep your documentation good. So anybody comes in, you can always see. Plus, you can also learn retrospectively from what happened and how you did, your processes. Thank you.
Has said that it comes under procedural exemption where you are very much trained to do it, and you can actually do innovations in that while doing. We do so many innovations intraoperatively always, like that's how we advance. And so this is
Yeah,
kind of
my
treated
point
as
of asking that question, one
Yeah.
was to address the so much of ambiguity and
Yeah.
fear regarding what we are doing
Yeah.
when regenerative is concerned. The second was I wanted to bring out this point of documentation.
Yeah.
We are no doubt doing a lot of things, but what exactly? How do we
Yeah.
document it?
Yeah.
What exactly goes on paper? And when retrospectively there's an audit or anything, we know exactly what we had done. So that
Yeah.
is very important over here.
Yeah.
Coming back to
Problem also come when there is a complication.
yes.
Because suppose if you are doing fat
Yeah, when
harvesting,
everything goes normal, nothing happens.
Yeah.
That
so ideally fat harvesting should be done by a surgeon or a plastic surgeon. So if somebody else is doing, they will ask you, have you been trained?
Yeah.
Have you received any training?
Right.
So normally in like outside India, each person if you need to do certain number of those procedure. And of course the complication, because if plastic surgeon is doing, then the chances of seroma, asymmetry, atrophy, they will be less. So if you are doing on a female, you should be very cautious. So these are the things when complication happen. If patient is happy, everyone is happy.
everything is happy. Yeah.
Can I add a simple comment to it, like the past discussion what Dr. Asa also said? So if I talk about like even rules in India or United States, so we call it like say PRP kit, it's class 2 device. India we call it class B, right, for blood and bone cell. So class B, class 2 devices per definition do not require any clinical trial. So what the regulations say is they have to be approved by US FDA, Indian CDSCO, CE from Europe, that's it. The moment you tie it up to an indication, that is when it becomes a drug or a device. So when they gave the approval to a kit, say PRP kit is CDSCO approved, it's the kit that is approved, not the indication. So how you tie it to the things, that's where they go in that we never approved it. When we talk about BMAC or something, same day, same setting procedure, they all fell into the procedural exemption. So I was asking Dr. Sharmila, and Dr. Ashok can tell me if I'm wrong. Orthopedic surgeons, they used tendons from hamstrings, quads, bone, patellar tendon bone as a gold standard for ACL reconstruction, right? We all talk about all day long about, oh, minimal manipulation, homologous use. Yes, we copied all that from US FDA. Since when a tendon is homologous use for ligament? When did you get the approval to do a tendon graft to replace a ligament? It falls into...
Yeah. No, so it's like, yeah, it's like this, okay. So the kit is approved, okay, by the CDSCO. How you process the product and use it on a human being is entirely the physician's choice, provided it is same day, same minimally manipulated procedure. Okay, you don't require do you require approval each time you're injecting something and you're doing some different combination than what is described in the book? No, you simply take you use your training and your intelligence and then you go about it. So this comes under the same one, if I'm not mistaken, right? So there is nothing to get like scared of. Why this is happening is because probably the pain physicians are not trained as surgeons, and there the whole thing is getting haywire. So for adipose stem cells harvesting, like Dr. Ashok said, anywhere else outside India, we have to show a training certificate that we have done 30 liposuction procedures under a supervision of a plastic surgeon before we do even one. Okay, so those rules are not there here, and that's why probably it is you don't have a backup to say that okay, I'm trained in this. No, I think that is where the problem
that's where
is
it
coming.
makes the difference. Yeah.
Success is going to be when you're going to do integrative practices. So it's not like me who's just in the lab or me just who's training,
Yeah, it has to be a team. It has to be a team
orthopedics,
working on the
so
same.
it has to be, because I think we have all been trained on different aspects of it. It's only when we come together that's going to sustain the field. If we are going to, I don't want to give a simile, but it's not like the story of the crabs where we pull each other down, but it's like we should support each other's part and what we are doing and train towards that to achieve that. And as Ashok was mentioning, whenever there's a complication, we are not seeing the suing culture here, but it has definitely started in GCC or Middle East or many of the other countries other than US, Europe. So wherever we are going, if you don't want to be regulated very heavily, take the help of your colleague. It's as simple.
Yeah, I think a comprehensive, a holistic approach towards the patient's management is the key to it's the cornerstone there, yeah.
So I have one question to Ashok sir. So the early stages, it is simply that articular pathology is not there. The second stage after only the synovitis and intra-articular stages are. In that aspect, early stages, simple intra-articular injections.
Yes.
Will it be helpful?
Yeah, it helps. Because many times they are having just synovitis, capsule is thickened, mild diffusion is there. If you inject PRB without HA, it works.
I think my last question to wrap up the management part of the thing is, there's a lot of ambiguity again on whether there should be rehab for these patients and in which category or which staging and what it should be. So would anybody want to add on to that?
The evidence is if like there is a good randomized RCT, they compare non-weight bearing with the crutches versus the nothing. So evidence shows that if it is a early AVN and if they are using partial or non-weight bearing, the results are little better. Progression of disease is get stopped or delayed.
Halted. Anybody else also would want to add to that?
I actually wanted to ask Dr. Das. Yesterday I was floored by his commentary and the way he was conducting the session. You know, Dr. Das, you were really very nicely showing the procedures and, you know, I think when you're seeing such a lot of volume, what do you, you know, tell others who have probably seen? So when I see Western trained doctors, they're usually done 10 AVNs, but when I ask an Indian doctor, they would have done 50 or 70 AVNs. So what do you think is your experience?
No, I already told what is my practice. If the patient is in the stage 1 and 2, where it is actually the right stage to intervene, so and that intervention should be done and by an orthopedic surgeon, because core decompression is the plus something else is the best evidence. So that is these two stage where I myself don't treat these patients. If it is stage 3 and 4, where the almost the replacement is definitely needed now or later. So that is the area where I feel our role is more important there. So there we can go ahead with the either by the nerve ablation for the treatment, or what Dr. Ashok was telling, even in this stage, the regeneration therapy can reduce the pain by targeting the synovitis and the capsular, the inflammations. So there also we have some role, and there we can go just intra-articular PRP also gives good result. I told already my experience is similar, that these patients, we can give pain relief for a certain period. And there also, our goal is not, or we are not going to promise the patient that this is going to prevent your replacement. You have to go to the replacement sometimes later on, but our aim is to give you a pain-free life at least for a few years so that you can defer the replacement surgery.
I think we have reached to the... Yeah, we are on time. We've just finished the discussion on time. So I think, yeah.
Regarding the medical management, is there any role for supplements, vitamins, any other medicines that can be used along with the
Bisphosphonates, though, bisphosphonates have a role to play. That is there.
Yeah, there is a definite role of bisphosphonate, but the evidence is not like very high, but it helps in some patients.
And again for, yeah, and again for this question, doctor, again for this question, I know and I see and I always tell, and we are evidence-backed again, that don't just advise supplements blindly. Get a basic workup done, do it every 3 months, change the supplements accordingly. I see hundreds and thousands of patients on calcium and D3. That's not the only thing that they need. So, you know, supplement and the whole jargon now, and that is, so there are going to be strict regulations around that as well coming. So far they are under the radar, but they are saying that this is what will be required in future, you know. Kind of.
Anticoagulant or a low dose anti-inflammatory steroid?
Yeah, special steroid, no. But aspirin or anticoagulant, yes.
Yes.
And especially after COVID, that's ecosporin. I think, I don't want to promote any company, but that's something which is a requirement now, because after COVID, it is a unfortunate, you know, event that we are seeing. So yeah, and I know that the time is.
Thank you so much, my panelists and everybody over here in the hall. It's been such an invigorating session. Everybody has taken very important part into this discussion, and I think the bottom line here is a vigilant probe into any of the patient who comes to us, and a multimodal management. We all need to come together, whether it is the orthopedicians, it's the spine surgeon, or it's the pain physician and rehabilists. We all need to work together towards achievement of our goals for these patients. So I think there we achieve it when we are together. Thank you so much.
Thank you so much, ma'am and sir, for this wonderful discussion, this wonderful panel discussion. So now we are going to give a certificate of participation to Dr. Gautam Das sir and Dr. Namrata ma'am. Felicitation, sorry. Now to Namrata ma'am, a certificate of felicitation. Thank you, ma'am. So with this, we now end our panel discussion and we move on towards fifth session. So we now move on to our fifth session. So I'll be calling the chairpersons for the session, Dr. Deeposri Bhattacharya ma'am, Dr. Shora Borman sir, Dr. Manish De, and Dr. Kirti Satish Pawar ma'am. So Dr. Manish De and Dr. Kirti Satish Pawar ma'am. Ma'am is a pain physician who is working in Siddhivinayak Pain Relief Center, Baramati. And Dr. Manish De, who is a consultant anesthesiology, pain and palliative care physician working with CMRI, CK Birla Hospitals, Kolkata. So the first session is for adhesive capsulitis, USC guided 3-in-1 procedure by Dr. Harshida Surange ma'am. Okay, so next is how to improve the quality of PRP by Dr. Surbhi P. Bhagat. our session now will be How to Improve the Quality of PRP by Dr. Surbhi P. Bhagat ma'am.
We welcome Dr. Surbhi madam. She is associated with Indian Society of Pain. She's a fellow of Advanced Interventional Pain Management. She's a diploma. She has got multiple diplomas. I think we can start off with the lecture to cut short. Thank you.
Thank you. Thank you for that introduction. So, we have been talking about PRP since morning, the quality and quantity. Dr. Kumar, Dr. Sharmila, and all of the eminent faculties have already told how do we improve the quality of the PRP, but I just want to highlight for the basics of it so that it can, you to know the basic, what is PRP? Let's start with that. It is a concentrate which contains platelets more than normal. It started in late 60s and early 70s for the first time, and it is obtained by, this is very important, slow centrifugation of the blood when the RBC and WBC settle down at the bottom and the platelet-rich plasma is left above. So then we centrifuge at the second time, which is at high speed, to prepare more platelets, which is plasma which is rich in platelets. So when I started my practice, say almost 8 years ago, for thinking about regenerative and how to get these platelets, there were very few kits in the market. And as we all want to practice evidence-based medicine, I was just scratching my head and seeing, we need some 7 times concentration, then somebody said 10 times concentration and above. So every time I do the patient, I used to check the concentration. But never I was able to get 3 or 4, sometimes hardly 7 times concentration. So I really didn't know, what to do. So then I came across RegenX 5 years ago, and I saw that they have multiple centers across. They have developed a patented formula, something called a super concentrated platelet. So I approached them and to bring it to India. So here now I have a formula and a technology where we can exactly get the amount of platelets what we want. So Dr. Kumar was telling in the morning that we need to have at least billions, 10 billion platelets, 10 times the patient's platelet count. So we know that platelets have growth factors that trigger, they kick-start your regenerative, stimulate the tissue regeneration like an espresso shot. So, and it is like when you inject the platelet, it is like a time-release pill. It doesn't disintegrate immediately. It takes period of a week or so before these growth factors are released. And they orchestrate a response for regeneration. So this is about autologous platelet-rich plasma, which is used to treat, so stimulation, speeding the healing, shortening the healing time for the injuries, and that's how it decreases the pain and promotes repair and growth. So as I said, we have various kits, so various centrifuge machines, and the companies, they will give you different RPMs to speed. So depending on what you are using, you have to do a soft spin at say 15,000 RPM initially for 10 minutes, then procure the supernatant, remove it, again take the 2/3 of the plasma, and then again centrifuge at a lower, higher centrifugal force. Here what we do is we make sure that we have centrifugal force and we work at lower centrifugal force. So there was something called as RPM and RCF. So we focus more on RCF, the centrifugal force, and the temperature. And this is must. So we have a flexible lab platform where we have a 100 square feet lab, which only focuses on doing regenerative material procuring. So this is a biosafety cabinet here, which you can see, where all the products are done under safety precautions and they are prepared. And if you see, this is the first US FDA approved centrifuge, which is now given out by RegenX, and we have acquired it. So we do not add anything in the concentration, any foreign particles or chemicals, and we can derive 7 times, 10 times, up to 20 times the concentration of the platelets.
So we have a candidacy criteria. So if there are young patients, we use 7 times and 10 times the platelets. If middle age group, we use 10 times and 14 times. And if the patients are more than 55, then 20 times the concentration. Now that also we have different structures. We inject in the ligaments, we inject in the meniscus, we inject intra-articularly. So different concentrations are used based on the pathology and the age group of the patient. So POR classification was also mentioned in the morning, and we do only single injection. If required, boosters are given at 4 to 6 months. So this is how it is different. The super concentrated platelet, what we call, in a flexible lab platform, and patients don't need further treatment. It acts for minimum 2 years. That is what we say, and we have done the research over 20 years. So multiple structures are treated at the same time. This is something called as growth factors, what we get through your platelet lysate, which is already, platelets have released the growth factors. They are like an immediate release pill. So we prepare this in our own lab at the same time from the platelets. And the alpha granules which are released, they contain growth factors, so immediately it has an anti-inflammatory action. So we use for nerve hydrodissection, we use in the epidural space, transforaminal epidural injection around the nerve. And the concentrations vary depending on what pathologies and what structures we are treating. So as I said, the OrthoRenew has patented this formula. From Region X, we have received this. And at each step, this formula is applied. And if it is a platelet, we use it for mild arthritis, small tendon or ligament tears, partial tears, and small annular disc tears also. If it is a platelet lysate, it is used for treating the irritated or pinched nerve, around again for the small tendon when you are doing fenestration or hydrodissection, and any damaged peripheral nerves. The laboratory area I already showed you, and we make sure there is no contamination. So what product we get at the end, if you see, compare, we were talking about bloody PRPs, and the PRP should be with yellow color, which is shown on the left side. So this is how we are able to achieve, we eliminate the RBCs completely from the PRP, so that we don't get the undesirable effect of the RBCs. Blood analysis is done, patient cell count, CBC, platelet count should be normal range. We have a formula in Excel based on the hemoglobin level of the patient, say 10, 11, 12, how much we can bleed the patient, what is the hematocrit level of the patient, and depending on the structures treating, we analyze or we calculate how much blood I need to take. So anywhere between, it can be, if I'm using only the platelet lysate in the nerves, it can be as low as 40 ml to 50 ml. If I'm treating the whole knee joint with the ligaments, with the meniscus and intra-articular, then I may require anywhere between 150 to 200 ml of blood. And to improve the quality, we have been saying since morning that we have to stop all kind of steroids 4 weeks before and after the procedure. Non-steroidals, statins, we make sure that if it is really not relative contraindication, if patients are able to stop, we stop that also for 2 weeks before the procedure. And blood thinners are stopped at aspirin, especially 10 days. And if patient needs that and has cannot stop the blood thinners, then you can put on heparin and stop, immediately start 1 hour after the procedure. Smoking and alcohol, again, you have to look into to improve the quality of the platelets. Plus the supplements, we have been talking about curcumin, B complexes, omega-3 and etc., which are very important. So these are the pioneers. They started, Dr. Centino and Dr. Schultz, they started regenerative medicine, thinking of treating, sports athletes 20 years ago. They sat down and thought, created this research lab. And now with expansion, they have more than 120 centers across the country, and we are the first one in India at Santa Cruz. We believe in this model of treating. So it's called a SANS model. So right from what you see is we don't see just the intra-articular structures, the stability, the articulation, what is the neuromuscular progress of the patient, and whether there is an asymmetry, we correct the whole joint as a whole, holistic approach. So patient journey, always our image guidance, the ultrasound guided evaluation is also done. Ultrasound is like a stethoscope. All the musculoskeletal joints we have to evaluate with the ultrasound. This is the lab. We have multiple tubes. We, take the blood. Each tube is of 8 ml. And plus the best training and skills are provided to the physician. So this is how we are different. Rather than treating just the joints, all these structures are diagnosed and injected at the same time around the big joints. So this is how the leaderboard will look like if I'm treating a patient. Say this is a patient, I'm treating knee and elbow simultaneously. So you can see here that the concentration I have received of PRP is, I've got 10x 3 ml, I have got another 10x 3 ml. So 3 ml is for elbow, 6 ml for is the knee joint, 14 times is another 6 ml I've got, and the platelet lysate mixture I've received two tubes of 8 ml. And there is a platelet poor plasma also, which is 10 ml. So all these are the structures we inject at the same time. Intra-articular, there's patellofemoral joint, medial collateral ligament, medial meniscus, lateral collateral ligament, IT band, popliteus tendon, and so on. So multiple structures are treated simultaneously. Same is with the shoulder. This was a shoulder patient whom we treated with partial supraspinatus tear. So this is how we prepared. So here also you can see the 14x goes into the joint, 10 times goes into the rotator cuff, the bursa, and we mix the platelet lysate so that the process of the growth factor really starts and the platelets can be like a delayed response. So this is why we are different. So we have a lab platform. Each patient has the data we collect and it goes into the RegionX registry. So we analyze how much percentage of patients got better, whom need to follow, or we had to give the second injection or call them for the third time. Research is ongoing and image guidance is must. Hybrid technology, C-arm, ultrasound, both we use. And specialists are there. So we have 200 plus network of doctors whom we can reach out to have any kind of support. If there is any difficult patients, we can always discuss with them. So this is my team at OrthoRenew. My mentor, Dr. Paras Shah, he was from Kansas City in RegionX, USA. And we have 2 lab technicians with the extreme end, which they help us in getting all this material ready, regenerative materials. And we also conduct training program, interventional training program in advanced and basic module also. So whoever wants to connect can get back to me. So that's about me. Any questions?
Thank you so much, Surbhi.
So it was a repetition actually of the morning we have been telling about how the quality, but what how differently we practice, I just wanted to highlight.
It was wonderful and very specific.
Thank you. I hope I finished in time.
Madam,
I think we will take the questions later on because we are all having flights.
That's okay. That's okay.
Tied up.
Okay.
We call upon Dr. G.K. Kumar for the next lecture.
Where is my presentation?
He doesn't need any introduction, so we will go for the lecture.
Hello. It's a very good afternoon. And slides are not coming? Yeah, thank you. So the question is very simple. The ma'am gave the topic. Do the disc or not to the disc? Very simple questions she asked that. The role of orthobiologics. Yes, again, I don't have anything to disclose it. And of course, this is the institute I work at. And the key factors are LBA, low backache causes, diagnosis, how you are making the diagnosis, management, and what we are doing, minimally invasive pains, spine interventions, and finally the part is what is the role of the biological solutions. The incidence is, you know, that's globally, it's a significant, and in India also, the same thing. Causes may be so many things. Among that, you have the development art, it is a purely by disc. After finding out our pain generator among these things, so by means of doing detailed history, clinical examinations, investigations and diagnostic interventions, you come into the conclusion that the patient's back pain is due to the disc only. Then discogenic low backache. That is, we concluded that the patient is probably or definitely suffering with the discogenic pain. So the problem is the variable presence of discogenic pain. Maybe without internal disc disruption, without also that, the patient may have the disc herniation. Without herniation, the precise mechanism is still debatable. Low sensitivity and specificity of the clinical and investigation methods. So, discogenic low backache management wobbles around that. Physical therapy, pharmacological therapy, interventional therapy is minimally invasive. Maybe diagnostic interventions, although, yeah, of course, intradiscal therapies, surgical interventions with diffusions, and disc replacements. So many options are there. Definitely, there is a good room for getting confused ourselves and confuse the patient also there. So, the role of the orthobiologics. Where is the role of the orthobiologics? Yes, they have the fair enough role because a lot of inflammatory soups are released around the joint, around the nerve. There's a fair enough chance of orthobiologics may play a role, definitely. If you want to read about LBA, you cannot miss these slides. It's inevitable because it tells the story what is going on. So what is the role of orthobiologics? Interleukin 1 is increased, tumor necrosis alpha factor is increased. So whatever the way you are reducing them, definitely patient may be get benefited. So they have the direct differentiations, may turn into the targeted cells. The mostly we are dependent upon the paracrine cells and immunomodulations. The first one may happen, but the second and third one definitely going to happen. So the intradiscal, what are the things are available? Growth factor, why it is having some kind of the interest? The growth factors are released from the platelets. Yes, what are the things are going to help us? Of course, PDGF, TGF beta, and VEG, ECF, and fibroblast, growth factors, IGF. These are all the very, very important one. Will make our disc, injured disc to heal. So, what are the roles of orthobiologics in intradiscal areas? In disc degeneration, inflammatory cytokines are produced without any doubt. So, biological approaches based on the stimulation of the anabolic process, modulation of the catabolic process, and provision of the new cells if possible. So, PRP injections and the MSCs have been utilized commonly. So, now coming to the indications, is there any specific indications, sir? I'll tell you the one book which have the comprehensive details about this orthobiologics, especially in spinal procedures. The last slides will be my references. Biological or cell-based therapies are recommended in the following patients after, this is the one slide I'm going to read word by word. After failure of the conservative management. If the patient is suffering with unremitting spinal pain without extremity pain or greater than 3 months of the durations. The pain is unresponsive to all appropriate methods of conservative therapy, including fluoroscopic direct or epidural injections. Patients should have done all possible investigations. If it is put into the patients, you may think of the orthobiology. It is not the clear-cut FDA approved class level 1 indications are there, but it is the logic indications. What are the evidences for that? Most of the evidences are in the discal level, level 3 only. This is the one good evidences we have that done with 1 year, 2 year, 3 year, 18 months, 12 months, 6 months follow-up. All the things are, they shown the significant clinical improvement. So the qualitative evidence were assessed at the level 3 with this thing, and pain and functional integrity scores are improved with the thing. So it looks satisfactory, but the evidences will be wobbles around the level 3 only. So the intradiscal injections for bone marrow concentrates. A lot of articles are there. There are also studies which have the results show there is a significant difference between the control group and injection group for improvement. Then the another studies with the Dr. Alturi is involved that outcomes are assessed 1, 3, 6, 12 months. The results show significantly improved, but these things are, they are not simply injected into the disc. They are paradiscal, around the disc, facet joint, even the SA joint, wherever they think so pain may be arising from these sources, they have the multiple injections, not single disc alone there. So the little bit of studies are there. All the things are related higher initial may be potential for the greater improvement. The intradiscal BMAC may be effective in reducing the pain and improve the clinical functions. None of them are producing any radiological evidences. So intradiscal evidences are the evaluations shows around the level 3 evidence variable but promising findings in various studies are there. So what are the other options? Epidurals are there? Yes, of course, epidural also you can give it that. And there is a valid reason for choosing the epidural way. And other administrations of the plasma lysate, all the things are there, but the levels are always around level 3-1. I mean, the evidence is always around level 3-1. Why we want to do that? Inject this solution into the epidural space or into the disc, because right now we don't have any other choice other than the steroids. So you know that the problems with steroids are there. Particulate steroids with the biological products, you can always compare that. The safety profiles with the biological products are a little bit better than the steroids. So epidurals also, we have some kind of the indications are there. Most of the indications are mostly what we are facing the clinical cases. So to conclude, biological cell-based therapy is recommended in patients after the failure of the clear-cut conservative failure management, unremitting spinal pain without extremity pain, that is a radicular pain, greater than the 3 months of the duration. Pain is not responsive to all appropriate methods of the conservative therapy, including the fluoroscopic directed or epidural injections. Patients should undergo the necessary complete investigations. Orthobiologics may be the alternative, but viable, convincing, but not confirming the treatment options for LBA. Standardization to be done, and regulatory ethical guidelines to be followed without any fail. So if you want to know more about the thing, not only the intradiscal, anything about, this is a very good book by Machikanti, you know about him, and Saira Malturi. This is a very fantastic book. They have given everything about that, how to do the procedure, how to select the procedure, what to not to do, also that. So thank you very much for that. Again, I have taken the opportunity to invite you be in Chennai for these days, because there is a big conference we are planning that. We need your valid participations. Thank you very much. We will announce the other proceedings as soon as possible. Thank you very much.
Thank you, sir, for the wonderful lecture. So one question, like, are there any prospective randomized control trial comparing biologics with conventional corticosteroids?
So most of the trials are comparing with the saline or the sham group and with the steroids only.
So there has yet to be done. So this.
It is there, 1 or 2 studies are there. That's it that I mentioned. That's articles.
Yeah,
Go through that. It is a review article producing like that.
Okay.
But you know that LB is highly variable, and it needs whether that particular disc is producing the pain generation. We need the discography also. They have the clear-cut guideline. Only one thing is the how to do this kind of the injections. Little bit variable from our diagnostic discography. You have to keep the needle at least a minute. Don't take it out the needle just like we are injecting that, and don't give any contrast. These are the 2 guidelines they are giving that.
Thank you, sir.
Thank you, sir, for your discussion. And I will ask Dr. Sunita Lawange ma'am to please come on stage for her talk on USG guided trial in musculoskeletal pain. She needs no introduction. She is a known face in all over India in pain. Ma'am.
Good afternoon, everyone. So this is something different from regenerative medicine. Now we're continuously listening about PRP and all other regenerative things. So I am from the city of Oranges, Nagpur. So hence, welcome everyone for this session. My topic is again on ultrasound guided dry needling, which is going to solve the muscular mysteries. So how it is going to solve? So what are basically the trigger points? So trigger points are nothing but hyper-irritable nodules. They are present in a taut, tight skeletal muscle band. So why there is tightness in the muscle? So that is due to overuse of muscle or some injury, some trauma, or some neurogenic inflammation. So what happens to the skeletal muscle is some trigger points develop, and because of these trigger points the muscle becomes very taut and tight. This results in autonomic dysfunctions as well as motor dysfunction, pain, tenderness, and overall the patient complains of pain which is at the local site as well as it is referred all over to that region. So what these trigger points do, they release inflammatory mediators like neuropeptides, cytokines at the site, which results ultimately, if not treated, in peripheral and central sensitization. So this, can you see the trigger points? Yes, they can be seen, they can be felt, they can be visualized, as well as you can visualize them directly under ultrasound also. So they appear as fibrous bands, and most of the pains, there is disability, stiffness, weakness, and reduced range of motion. So what is pain and tenderness? That is only the tip of iceberg. Actually the problem lies in whole muscle. So wherever there is problem, whether it is neurogenic, we all know that it is not neurogenic or neuropathic, it is neuromyopathy. So we are treating the nerves. We are always focusing on that. Yes, this nerve is there. Okay, I'll treat that. I'll do the MIPSIS. I'll go for the advanced interventions like radiofrequency. I ablate them. But then again your patient comes back and he says, the pain has gone, but then I'm not able to do my routine work. So what you will say? You will say you go and do the physiotherapy. So then he's ultimately sent to physiotherapy unit. And they say, yes, it will take time. Sometimes it's take 2 months, 3 months, and they continuously go on doing that. But then also they are not happy. in this era, this fast era, we are not going to wait for such a long time. So we have to treat that. It is not only the pain, but we have to treat everything. We have to treat the patient as a whole, the muscle as a whole. So the muscles are basically the primary pain generators which are present in the form of trigger points. But they are not only the pain generators, they are also expressors and sustainers. So whenever there is any nerve lesion, what happens is there is increased firing at neuromuscular junction, which causes muscle spasm, sustained spasms, and these spasms, they result in development of trigger points. So they can be active, they can be passive, they can be secondary. So this pain, not only it is at the local site, but it is also referred to distant sites, and it impairs the motor function, which leads to disability. The muscle is dynamic. We are not going to, if there is some injury, we are not going to stand still throughout. So we are going to work. So muscle is a dynamic organ. It keeps contracting and functioning in spite of injury. So what is happening is the trauma is going on increasing. So ultimately what happens is the overuse results in muscle tears, what we see. So these are the active trigger, these are the various types of trigger points, and if you get a patient when the trigger point is active, it is very easy, it is reversible. But then patient is telling pain somewhere and the trigger point is at other point, so that is your referred pain. So that is why you have to find, sometimes they are latent, but suppose there is trauma or injury, fall, they become active and suddenly the pain occurs. So one must know what are they and the referral patterns. So this is what happens when there is muscle injury. So whether it is injury, it is postural imbalance, stress or overuse of muscle, it releases in increased acetylcholine release. So this results in increase in the contractions. Ultimately muscle starts contracting more and there is more release of intracellular calcium. And this all results in muscle contraction, which because of overuse of muscle, because muscle is now tired. So what happens is there is ischemic hypoxia. And because of that, substance P, bradykinin, serotonin, they are released. So this vicious cycle keeps on rotating, and ultimately when a patient comes to us, he is in severe pain. And what comes to our mind is that yes, this is neuropathic pain, I have to go and treat by various MIPSs. So one must be able to locate where it is. It is very, very important to find out the trigger points, and once you find that, that is the point of maximum tenderness. And when there is jump sign, whenever you give a little pressure out there along with local twitch response, and definitely there will be restricted range of motion because patient is unable to do the routine activities. So whenever such patient comes, we all first try the drugs, that is the pharmacological management, but those coming to pain clinic, usually they have tried everything and then they come. So that is the chronic pain which we have to treat. So what is intramuscular stimulation or dry needling? So this is one of the treatment for chronic pain of neuropathic origin. So what are these needles? They are fine disposable monofilaments of 32 gauze, and they are inserted at those trigger zones where whenever there is trigger point, we give trigger point injections also. But when there are lot many trigger points, are you going to inject everywhere? No. So that time when 2 or 3 are there, well and good. But then if the whole muscle, along with that the whole group of muscles are involved, after giving that you can go and relieve this and reverse the condition. So what acupuncture, it is totally different. Out there they select some meridians and points. What we are doing is something different, and it was Dr. Chan Gun from Washington who introduced this as this is a neuropathic pain where muscles are also involved. So what happens when there is neuropathy? The nerves, they are not doing the normal job, and hence what we try to do is we try to treat the neuropathic pain, but then along with that, if we treat the muscular aspect also, the neuromyopathy, we are desensitizing the sensitive areas, mainly the muscles. So you see the diameter, and the acupuncture needles, they are of 0.25 millimeters. We can use something else also, but these others are hollow. This is not hollow, this is a solid needle, and the diameter is very less. So definitely we are using it just because these are only available. These are the various sizes, so this depends on the depth of muscle. So this filiform monofilaments, they are solid needles and they are used before putting the needle. You must apply cream like analgesic cream like Emla or Prilox, say around 15-20 minutes before, so that the patient will not experience pain, because muscle bands are very tight. So whenever you put the needle, patient is going to shout. This is the way how they are put in a muscle as a whole. So what is the difference? Again, I'll just repeat it, that in dry needling, we used to target only the painful point. Wherever patient will say, yahan dard ho raha hai, yahan, so you are going to put there. But here, you must know the anatomy, so you are going to target that whole group from the origin to insertion. So the whole muscle is targeted. Here it is in depth because I can see. Earlier I was afraid, because if I put the needle, what will happen? The patient will, I may damage. Suppose I am near the ribs or somewhere, I may damage that area or some vital organ. So that time we were very much superficial. But when ultrasound came, we could see the muscles, we could see what is going on inside, and hence in-depth training, it was easy for us to go till the target. In dry needling, the goal was to reduce pain and stiffness, and yes, it is okay, then patient used to go back. But here we are treating not only pain, again I'll say it is the disability also which we are treating. In dry needling, since we didn't knew the whole muscle, what used to happen? We were happy with 6 to 10 needles, which were removed only after a few seconds. But here, we target the whole muscle. Sometimes the needle number is, say, more than 30 also, and these are kept for more than 20 minutes. Since it was blindly done, there were much fear of complications. Out here, nothing. And only the side effect of ultrasound guided dry needling is some bruising and soreness. So what do you do when you treat neuromyopathy? So it has two manifestations, sensory as well as motor. In motor, there are taut bands. Because of those taut bands, continuously we are using them, so there is going to be micro tears in this, which will further cause inflammation. Out here, it is not only the muscle, the both parts, say the agonist and antagonist. Flexors along with that extensors also get the equal amount of brunt. If it is abductors, even the adductors. So the both agonist and antagonist muscles, they all are involved, and hence that is why we see the secondary and satellite trigger points out there. Here there is no coordination between the muscles. They are doing their own, involuntarily they are moving throughout, and when you see in ultrasound, you feel as if the whole muscles are dancing out there. So this is basically because of a noise in the motor end plate because of muscle contraction. But and the sensory aspect, there will be inflammation, there will be spontaneous pain, reduced range of motion, and along with that referred pain also. Apart from that, if autonomic involvement is there, then patient is going to complain of allodynia, hyperesthesia, some crawling sensation out there, which can be treated with somatic blocks or radiofrequency. If there is sensitization of the at local level, this is ultimately not treated, it will result in peripheral and hence central sensitization. And hence, ultimately there will be sympathetic nerves which will be recruited in the muscles. So now it is the sympathetic aspect which has been showing us that is the patient suffering from CRPS. So ultrasound guided dry needling, it is an extensive and comprehensive version of dry needling. And here what you see is local twitch responses, not only in the agonist but also in the antagonist muscles. And the co-working muscle, there won't be any pain, only there will be reduced range of motion. So what we think, there are more than that of the these trigger points out there, and hence pain and tenderness, as I said, it is only thing which we are thinking, but no, we have to treat the muscle as a whole. So when you see the muscle as such, the upper picture out there, this is the normal picture. So here you will see hyper and hypoechoic bands. So red muscle, it looks hypoechoic, whereas the connective tissue, it looks white. But when you see a muscle which is tight and taut, what you see out there is a picture like this. So definitely by seeing this, when it is you imprint this in your mind, you come to know that no, this is the muscle which needs treatment. This is not doing the work properly. So the two ways, you can go direct or indirect way, in plane or out of plane. So usually we put few needles, see the depth, and then there is no more need of ultrasound machine. What we do is, we can, once we know the depth, we can proceed further. So in plane, out plane, this is for knee, ultrasound was done. Dry needling was done because this patient is of osteoarthritis, given PRP, but the stiffness was still there. So 2 to 3 sessions of ultrasound guided dry needling, it helped. This was a patient of operated inguinal hernia, continuous pain, not getting, everything was done, all medications, all blocks, everything done, but then she continuous, one only complaint was there, and it was, there is tightness, something is pulling me from behind. So then we shifted for dry needling. This was periscapular pain getting referred to shoulder. So we thought this is a shoulder pain, but no, it was periscapular area where 5-in-1 block was given, and after that we did. Can you see the muscles and the needle going inside? When the needle goes, you see some twitch responses. So this is something which is elicited at the deep level when you put a needle inside. So this is a dancing type of picture. This is because of the noise at action potential which is occurring, and hence the patient is gets immediate relief, because what we are doing is we are trying to decrease that tightness by this measure. This was in thigh muscles. This was a very interesting case. You can see on the right side, there was 1.5 inch difference between these two thighs. In this patient, total hip replacement was done, and then this patient was unable to walk. He came limping and continuously complaining of pain. One can see the tight muscles and the spasm of those muscles. So that time we thought of going for dry needling, and immediately after one session, what was seen was the patient came walking next time, but now we are repeating, and still the procedure is, we are going to do 5 to 6 sessions in him, and let us see how he works. This was for intercostal neuralgia after giving intercostal nerve block and doing PRF. Bas ho gaya. This is hemifacial spasm. Hemifacial spasm, neurosurgeon has referred this patient. He had received Botox 6 to 7 times. He said, now I don't have money, I'm not going to go, because after 1.5 months, every time they say, you come and take Botox. So he said, can you do something out there? We did dry needling, and then you can see the patient immediately after this talking with us and smiling. So this was immediately after the first session. This was for occipital neuralgia, shoulder. So these are the benefits of dry needling. We are short of time, so I tried to show you few pictures and cases which we have done. So definitely one must keep this in your armamentarium when the patient is coming again and asking you that now what is to be done. You have given a block, you have done all MIPSs, but then also the pain is out there along with disability. Don't forget the alternative therapies. Exercises play a very important role along with strengthening and regular exercises. So always, it is not only the pain, it is your muscle, it is your mind and your body which has to be taken care of. Thank you so much.
Thank you, ma'am, for the enlightening discussion. Any questions, or we move forward next?
Thank you so much, ma'am, for that wonderful presentation. I would now like to request Dr. Kirti, ma'am, to please felicitate Dr. Surbhi. And I would also like to request Dr. Sameer sir to please felicitate our chairpersons, Dr. Manish De, Dr. Saurav Burman, and Dr. Kirti ma'am. Dr. Sunita ma'am is going to felicitate Dr. Kirti ma'am. So with this, we come to the end of our session 5, and we will start with our 6th session, that is a panel discussion on advanced knee osteoarthritis pain. For that, I would like to call on stage our chairpersons for this session, Dr. Pratibha Marche ma'am and Dr. Rachna Verma. Our moderator for this session, Dr. Anand Murugesan sir, and our speaker for this session, Dr. Sharmila Tulpule, Dr. Vijay Bhaskar, Dr. Deepostre Bhattacharya, Dr. Kirti Satish Pawar, Dr. Kiran Vehare ma'am. I would like to request Dr. Anand sir to moderate the session, please. Sir, over to you.
Very good evening to everyone. I really thank Dr. Krishna Poddar to invite me and to me having here, sharing my experiences to moderate this session. And it has been a lovely 2 days of the experience and the exposure here with all of my colleagues here. So this is a very interesting panel discussion. As we know, like knee is a very, very, very complex area in chronic pain. Like it is very, very a multidisciplinary area. Need to have a lot of players involved in knee pain and more so in advanced knee. So it's really so delicate to be a moderator in taking this subject forward. So I'll invite the speaker, Dr. Pratibha and Dr. Rachna Verma, and speakers, Dr. Kirti, Kiran, and Dr. Sharmila Tulpure also. Welcome you all here. So, like, I will take this discussion forward like I'm one of the delegates, like whatever the common doubts a beginner have in dealing with the chronic knee pain, especially in advanced OA knee. So, I'll first take the question to Dr. Kirti. So, in your clinical practice, so what percentage of patients with osteoarthritis knee will have a severe osteoarthritis, and what are all the challenges you face in treating those patients?
I think the most of the patients go to orthopedician when they are in the initial stages of osteoarthritis, and advanced osteoarthritis patient after visiting number of consultants, parallel therapies, physiotherapy, they come to us as a pain physician, as a last hope. So I think 60% out of OA knee patients are advanced OA knee.
Okay. And another practical questions, like, is it like, are they, you are orthopedic, you are anesthesiologist practicing pain, right? So like they come to you directly, or like they would have consulted few more specialists?
That's why I'm saying that after visiting so many consultants, they come to you as a last hope. And with various deformities, they come to us.
So in those cases, what are all the challenges when you see that patient first time, having been already seen by the many specialists, and then coming to you, especially with advanced initial OA, like we have sort of fairly a good evidences to deal with many of the procedures available in the armamentarium, but with advanced knee, it's a little tricky situation, and having gone through so much of pain and so met so many of clinicians outside, they come and then having a lot of expectations from you. So like how do you go about with those patients? Like
Whenever patient comes to me, I always think I'm not a nerve blocker. I'm a pain physician. So I always see patient as a whole. And even though I'm the 3rd or 20th consultant for him, for me, that is the first time I'm facing that patient. So I always go methodically. And I have, over the period of 10 years, I have seen more than 5,000 knee pain patients, and every year the knee pain patients are more visiting to me. That's why I feel that I have developed a protocol which is really useful to the patient. That's why without any mouth-to-mouth publicity, the people are coming to me. So I think as a physician, I see the patient first. I go with the blood investigations and other investigations. The very important investigations, what I feel I should do, that hemogram, because most of the patients are old, anemic. If they are having hypochromic microcytic anemia, we have to correct their hemoglobin levels also, because everybody focus on vitamin D and osteoporosis. Nobody thinks that see the patient as a whole. Second important investigation is the uric acid, what I feel. We should not ignore the uric acid levels. If these are high, we should treat the uric acid levels with febuxostat or xyluric, allopurinol. Then most of the pains are vanished. As Tulpule madam said, that many patients need the pharmacological treatment only. And very few patients needs the very higher regenerative therapies. So for me, hemogram, uric acid, vitamin D levels, and if patient is osteoporotic, I do, nowadays, I think game changer is the teriparatide. So I do the parathormone levels who are having high risk osteoporosis, and that is really giving me really good results. So these basic investigations along with the X-ray, ultrasound of knee, and bone density, these 3 investigations in a diagnostic wing I do. And then I think about the management.
What are all the non-surgical options you provide to your patients who is coming with severe osteoarthritis knee? And what is the real expectations? Like, would you discuss with the patient about the realistic outcome of those non-surgical options you give to your patients?
Yeah, when the patient comes to you, as I said, I have developed a protocol. So like a vaccination chart, I give the protocol to my patient. You might feel it very interesting that why I am telling on the first visit, because I think that there should not be any false commitment to the patient. We should be very practical, very realistic, because I might be the last consultant to whom they are visiting. I am the common man's pain physician. The people come to me because they lose wages, they can't go to the fields, they can't squat, they can't sit in the Indian toilets. And few patients are very hi-fi patients, they are from the Delhi, and like that patients are coming to me. So I feel that whatever we are offering to the patient should be applicable to the all sets of this socio-economical strata patients. So on first visit, I give the stepwise approach to the patient. First is the medication. And I think we are dealing with the nociceptive as well as neuropathic pain condition. So inflammation is the key, and knee is the compartment syndrome. There is an impingement of the nerves because of the osteophytes is the one reason for the knee pain, and the inflammation is the another reason for the knee pain. So we have to combine these 2 medications on first visit, and muscles are really under spasm. If you see the knee ultrasound, you will get to know the 3 muscles are very importantly involved in the osteoarthritis. I'm talking about only advanced OA knee. I'm talking only about the grade 3 and 4. If you ask me this question for the grade 1 and 2, my answer may be the different, but for advanced OA knee, The most important muscles involved is the quadriceps tendon. Second is the semimembranosus tendinosus is there. And third is the articularis genu muscle. Nobody sees these muscles which are involved, and they are causing the compartment syndrome. It is not the, ONE is not everything about the bone. You have to see the knee as a whole, means with muscles, nerves, and if you see the nerves, these are not 3 nerves which are important in the ONE, because more than 16 nerves supply the knee joint with different plexuses. So if somebody is producing results with blocking or doing cooled RF or RF of 3 nerves, and if results are not sustainable, it is because there is a multiple nerves which are supplying the knee. So whenever patient comes to you, you have to think first about the medications. If inflammation is high, there are 2 things whenever patient comes with the ONE. One is the dry knee and one is the wet knee. For me, dry knee is the degenerative knee, and wet knee where there is a moderate fluid collection in the suprapatellar bursa. If you do the ultrasound, if you see only X-ray, you might not be confident in managing the patient. But if you see the ultrasound or the MRI of the patient, you will understand what is the difference between dry knee and wet knee. If it is wet knee, we have to give the anti-inflammatory medications along with the muscle relaxants, because whenever patient comes to you, the many have received diclofenac steroids and some sort of ceratopeptides, but nobody would have given the muscle relaxant to these patients. And if you ignore those muscle parts, so first is medication, second is the myofascial component of the knee pain, third is the neurological component, means nerve. First you treat with medication, secondly myofascial component, third is the nerve component. You can go with the genicular nerve, you can go with the cooled RF, you can go with the RF and pacify those nerves. And the fourth part is the regenerative. Means once the inflammation is under control, then you think about the regenerative therapies in ONE. Yeah. And for advanced OA, there is hardly to regenerate inside the knee. So
I understand your systemic approach in dealing right from the clinical symptoms and clinical examinations, and it's not just the knee alone, it is the structures in and around the knee that could be the pain generator. So we need to identify the right pain generator based on your examination, and then start pharmacological management, spend more time in explaining the realistic outcome to the patients, and then go step by step. That's the approach. Okay. Next I take the question to Dr. Kiran. So how would you stratify these patients for these individual non-surgical procedures, like based on their age, comorbidities, and their damage to the structural damage to the knee? There are so many things involved. So patients may come with very elderly age group, 80, 90s, and also there are so many parameters that makes you to decide your treatment process. So how would you really stratify the patients?
Okay, as rightly said by you, I think this stratification is important because there are all different age groups that come to us. So around 45, 50 years, if they don't want a knee replacement and they are in a grade 1 and 2, like we already know that we are going for regenerative medicine. But for 3 and 4, if there are problems, then we, like I already said, that we explain a realistic goal to the patient, realistic like we give them options that this will be the, what you expect from the treatment. And I work in a corporate setup, and so mostly the grade 3 and 4 patients, they already go to the knee replacement surgeon. And it is the other way around, that the knee replacement surgeon sends the grade 1 and 2 patients to us for the treatment. For 3 and 4, if by chance like they have some comorbidities and they are not medically fit to undergo the surgery, only then we explain the options, like only the pain will be reduced and we can go for RF ablations and other procedures. So that is how it is. Like, I mean, they don't just walk in the grade 3 and 4. Usually they are, like we send it to the orthopedicians.
So that's the next question. At what point of time you will refer those patients to an orthopedic surgeon in higher grades?
Yeah, so exactly, like the, usually the orthopedicians only, they don't send those patients to us. Like in the corporate setup, all the patients go to the orthopedicians first. So the grade 3 and 4, naturally they keep the grade 3 and 4 patients, and the 1 and 2 only come to us. But by chance, if they are not fit, like for some reason, for medically not fit, or some family issues that they don't want to go for surgery, or higher age groups like 80, 85, 90, they don't want surgery. Only then we go for this. So I am very clear about my extent where I should go, and realistic aim should be there that grade 3 and 4, I don't think I'll be treating the patients. I'll preferably send the patient to the orthopedician, except those patients who cannot go for replacement, only then we'll touch those patients.
So I'm taking this question to Dr. Sharamala, which is the most controversial thing in the osteoarthritis knee about the steroids. So what's your take on steroids? It's a quick fix, or like it's a long-term harm, or like when we have to say strictly, no, I'm not going ahead with the intra-articular steroid anymore?
It's a long-term harm for sure. I don't recommend steroids intra-articular at all, not for the weight-bearing joints. If the joint is non-weight-bearing, like a shoulder, once in a while, it's fine. It doesn't do real harm. But what patients we get, they are treated with repeated steroid intra-articular injections and actually leading to steroid arthropathy. When we do the replacements, we actually can see the joints which are treated with steroids with a very bad cartilage and which are not treated with steroids, even though it is a degenerated cartilage, there is a difference in the quality of the cartilage. So actually, we have seen it with naked eye, that steroid is damaging. So no, I won't be at all advocating steroid. What I would tell is that if it is an effusive or wet osteoarthritis, that patient is coming to you with a huge effusion, you'll obviously drain effusion, and you want to put something which was steroid till now, that we used to think that okay, steroid at least will reduce the inflammation and the effusion. So what I have switched over to is injection ketorolac. So that will reduce the inflammation but not damage the joint. You get a breather to plan your treatment. It gets quiet for some time and you can discuss with the patient and take the next step. So Toradol, that is what it is called outside, but here it is injection ketorolac. So I take 30 milligram of ketorolac. I dilute it in around 5 ml of normal saline. Otherwise, it's very painful when you inject. And that's it, okay? It gives a very good pain relief. It's not a very long-term pain relief, which again works for you. You're not doing anything. It just gives a good pain relief for a month or so, and it doesn't give beyond that. So you know that patient is going to come back to you, okay, so for a definitive treatment, but at the same time you build a confidence in the patient that you've done something, it has worked, and so what you're telling next, patient will be ready to hear it also. You know?
Is there any downside of giving corticosteroids in advanced osteoarthritic knee pain when there is no scope of doing other non-surgical options in a setting like a peripheral setting, like we always
Yeah, I know what you're saying, okay, that the cartilage is not non-existent or damaged so much that what difference does it make what you inject? It's like that. Yeah, once in a while you can, okay, but then I would...
Because in advanced OA, there is no cartilage,
yeah.
so like we are just going to give them a pain relief.
So I would still want to do a PRP then, rather than a steroid there. Okay, so I would do a PRP with hyaluronic acid in such a case and give him relief with a healthier option than to still inject a steroids. That would be my really last option actually.
So in extension to this, I'm taking the question to Dr. Vijay about the regenerative medicine. So between the products of the regenerative, the biologics, like what is the rationale of choosing this particular biologic for this particular patient profile? Do you have any criteria for choosing any one particular biologic based on the patient profile?
So generally when it comes to regenerative therapies, when I'm planning my treatment for the knee, early 1 to 3 arthritis, the 4 it's a different ball game altogether. We do sometimes the for stage 4, we are forced to do sometimes. Most of the times for 1 to 3, we will start off with, we have the options of PRP, growth factors, and I actually started using platelet-rich fibrin, PRF I've started using, and the results have been good. So these are the options that we have, and on top of that, we've got the nanofat stem cells or BMAX. So my
starting point has always been the PRP with growth factor. I'm using both of them, and I also use PRF these days. So the PRF has been much better. The growth factor numbers have been much higher than the regular PRPs. So I've been using that. And in the first instance, if it is pure PRP, we also use the growth factors. So to speed up the regenerative potential that we have, the anti-inflammatory potential, we're using that. And on top of that, what we also use is the hyaluronic acid. So sometimes I use it all in one go, or maybe I'll split it into two halves. So in the first sitting, I normally do 3 sittings of this. So in the first sitting, I'll do the first half of the same, because I'm doing both sides, I'll split the same hyaluronic acid into 2 halves, 3 ml on each side. So that I'm not increasing too much on the volume. Otherwise, if you go more than 8 ml, it will start to give pain to the patient. So I'm using a little bit of hyaluronic acid, an amount of PRP or PRF rather, and sometimes the growth factors along with that, 1 ml or 2 ml of growth factor over it comes. So we're restricting on the volume, but at the same time getting better response. That's what I've been doing. But generally not on a first sitting, but a second sitting, I would also plan to do an RF ablation. Usually it is a cooled RF ablation. I don't do thermal RF ablation unless it is very much indicated. Usually it is a cooled RF ablation, and that will be planned generally on the second sitting because they'll come prepared for it. We have to get them fasted. I give it only under sedation, or rather deep sedation. So I use it that way. So that's the plan. Usually this should be, as we said, we'll have to assess them very well before, make sure that they don't have severe inflammatory reaction at the start. Otherwise, my experience is I'm not putting PRPs into the joints when they have inflammation. So I would wait for things to settle down. Sometimes I use a small dose, maybe 10 milligrams of triamcinolone, diluted and then spread out into the joint. That settles things down. Maybe about 15-20 days later, we'll bring them back to actually start the treatment so that they will also get the confidence on the doctors. So that's how we've been progressing, and we complete the treatment. On the last sitting, again, I'll do the IPRF with the hyaluronic acid, so to finish off things.
So then when do you suggest them about the MFAT and the NanoFat?
Yeah, that's a very good question. Originally, when we started doing it, I was sticking to my routine plan, what I've been doing, and when it fails, I give them usually, I tell the patient like 2 to 3 months is the minimum time, like 6 to 8 weeks minimum that you require to get a response to your regenerative therapies. So if they're not getting any response even at the end of maybe 3 months, then I will start to raise the point like, okay, shall we try doing these kind of advanced regenerative techniques? So if the patient is willing, we will go that way. If the patient is not willing, then we will see. In the meanwhile, I would be trying all the medical management with the rehabilitation, whatever I can do. So we will push it aggressively. We call them and
Why
then
not
push it
starting the
aggressively.
NanoFat and MFAT in the first stage itself in advanced OA?
Very pertinent question. So we started doing it off late because we need to get a bit more confidence in doing that. Originally we were doing it in very advanced OAs, or maybe patients who are failed with the regular osteoarthritis, the regenerative therapies that we are doing, PRPs and PRFs. So only if it was failed, we were introducing a new technique. Now that we are starting to get a little more confidence on it, now we're offering it even before, as I mentioned to you earlier, even for avian. It was failed, the plasma therapies led us to do the other nanofat techniques. But as the audit we have done, the response has been tremendous. So we started incorporating right at the start. Maybe into the second sitting itself, we are doing the nanofat now. So it's all the clinical experience. It is evolving as we go along.
Okay. So now I have a question to Dr. Kiran as well about the knee denervation. Yeah, Dr. Kiran, yeah. So like the genicular nerve radiofrequency ablation, so what's your experience? You do a first diagnostic block before you go into a thermal ablation. Like when do you say it is a successful radiofrequency ablation, or what is the predictor for the poor outcome of the radiofrequency ablation?
Okay, so obviously I go for the diagnostic block initially, Because as such, the patient is also not ready to pay such a lot of, for the RF procedure also. So initially, I do give a diagnostic block, and if there is a good pain relief, only then I go for genicular nerve ablation. And like initially, we used to do only the 3 nerves, the superior medial, superlateral, and inferior medial. So now actually there are many advances, and we are supposed to ablate the other nerves also. So the outcome used to be, around 50–60% pain relief. So obviously it was initially we were thinking that there was some failure in the procedure as such, to be frank.
So do you do anything else along with your radio frequency? Like you will combine any other things, like you do a hyalinase injection with that, or PRP with RFA, or like you do a standalone only RFA?
No, actually I prefer to do only one procedure at a time. So initially, like I said, if I give a diagnostic block, at that time I might go in for some hyalinase injection. And when I do the RF, then I do only the RF. So that is my viewpoint. Might be because, and like yesterday only you demonstrated all the other nerves. So till now I think we were only doing the 3 genicular nerves, and gradually we might,
That's what next question is, that like now newer studies are coming with more targets.
Yes.
So like papers are coming one after another about targeting more things, and lot of anatomy is getting redefined.
Right.
So I think we need to keep abreast
Go
with those
ahead.
developments as well.
True.
To have a better innervation. And my last question to the entire panel is about the evidences. That is another one. Research is
Can
one
I
area.
just have one question? So we are talking about the CRF, PRF, pooled RF. So I just wanted to ask anybody practicing the alcohol neurolysis for the genicular, because that has a very good evidence, very cost effective, and especially I am always fond of treatment modality which can be cost effective for the patients. And it is supposed to be like equivalent to the other modalities as well. So I just wanted the panelists to talk about.
So to be honest, I've been doing alcohol neurolysis, not for every patient, but as you see, when I'm doing it, usually I do my ablations on my second sitting. So if my ablations or the regenerative therapies, the plasma therapies, whatever is not helping the patient, and they come back on the third sitting, and that is when the alarm bells will go on. Or if the patient is okay on the third sitting, but then after 6 weeks I see them, usually 6 weeks to 8 weeks I see them again. But at that point, if they come back to say they've got more pain, that is when I'll consider and do the alcohol neurolysis.
And what are your results?
The results have been good. Actually, it started to improve much better. I mean, my patients are feeling much more
So
happier.
would you not like to go in first instance for alcohol neurolysis?
Alcohol neurolysis in the first instance. The first thing is, my first sitting is to try the block. The second is always the cooled RF ablation. The third sitting, actually these are all going parallel. For me, everything, rather than what ma'am has suggested, one after the other, I'm going all of them together. So there I'm running all tracks, because pain is not coming from one place. Yes, the cartilage is damaged, but then there is a biomechanics which is failing. Patient is slowly starting to get the varus deformity. They are failing, and then the muscles are damaged, the ligaments are weakened. So there's a lot of things which are going on simultaneously. So we'll have to address, particularly we as rehabilitation, we are supporting that rehabilitation. We have to take all tracks parallelly. So that's what I've been doing. So in that sense, giving alcohol, coming back to your question at the start, I've not seen a great deal of evidence for that, but I am actually throwing it as the last dice. So if I'm doing it, so I'll wait till the last minute, and then because we never know where all this medicine is going to spread. Alcohol, particularly when it is given, we are so close, sometimes it can get into the joint.
What is the volume that you use?
Sorry?
What is the volume that you use?
Hardly 0.7 to less than 1 ml. 0.7 ml is what I'm using. So usually it is that small volume. Yeah. And actually,
one more question.
Sorry?
That, like you were talking about, am I allowed to just? We were talking about the HA and PRP. So there is little bit of a controversy about whether both can be combined or it should be given one after other. So anybody would like to talk about that?
So it's like regulatory wise, you cannot combine PRP with anything because it becomes more than minimally manipulated. So you cannot combine it outside before you are injecting. But one by one, you can separately inject. So what we do is that we inject HA because it is acting as a scaffold basically. That's the whole purpose of putting HA with a PRP. So it is working as a scaffold and it stays there for some time, one. And second, it acts as a lubricant to initially reduce the pain. So you just disconnect the syringe and put the PRP over it. That's allowed and it's perfectly okay. It has given better results. We've got now literature which says that HA with PRP gives better results than only PRP or only HA.
So there is one thing I
might just pose a question
Yeah.
if you allow me. So with the dilution between the PRP, the excess synovial fluid which is present, maybe as part of an inflammation which is happening.
Yeah.
So there are 2 or 3 confounding factors here which might dilute your hyaluronic
Yeah,
acid.
you're right.
So should you, will it have an impact? The second thing is, should you go with higher Dalton, I mean like a higher concentration
Of PRP.
No, of the
Hyaluronic,
acid.
yes. So
Thicker
we
ones.
always go for thicker only, okay? Don't go for the lower concentration, that's one. And second, you do it when it's not an effusive joint, okay? So you have to do first the ultrasound, see whether there is any effusion, and if there is no effusion, it's like completely collapsed suprapatellar pouch, you can very safely do it. Gives very good results.
Okay, I would like to add something.
Yeah.
I would like to add something that when you are treating the patient with a very severe acute pain, when the patient comes to you with osteoarthritis, knee, you know that the patient has deformity, or even if the patient has grade 1 or 2, and if the patient has severe pain, and would you like to do PRP at that stage, or I do not do it? First, I would like to manage that pain, which could be with synovitis or without synovitis also. So I would like to ask any of you or all of you that, like, for me, see, NSAIDs are not always the right choice because they've been taking NSAIDs for long standing, you know. So NSAID becomes like a no. So how do you manage that pain? I will tell you my experience. There is a evidence American study I went through, and I'm using it in my daily practice, that I add a anti-neuropathic, like Kirti said, that you do give a muscle relaxant, because the muscles of the knee play a very important part in maintaining the joint, and the locomotion comes through the musculoskeletal system. So it is never about only the joint. So giving a muscle relaxant is a very good choice that decreases the amount of paracetamol or NSAIDs. Okay, so I always add a anti-neuropathic, which is in that evidence I came through. And plus one thing which more we can do is apply lot of local topical application of, you know, all these sumo gels, nice gels. So the topical application of analgesics, especially now I've come across 4% solution of Dynapar, diclofenac. So that is also a very good choice before we go into interventions, because in acute pain, most of the patients are coming to us because they have not been managed well, you know. We can't just wait for, you know, to get, so we have to first treat the pain, and that is also what is required of us.
Yeah, so most of the time,
multimodal. Yes. So anti-neuropathic plays a very important role, because not every time you can do a genicular RF straightforwards. You have to give something else. So pregabalin and duloxetine, these both are very good choices to manage that pain, apart from the NSAIDs, which we can't give every
And
time.
those who cannot afford for the regenerative therapy, the long-term pain management
Very
with the
good.
gabapentin and non-triptyline,
Yeah,
it's very important. And with the low doses of this, and they can continue.
Pregabalin and duloxetine, I don't know why gabapentin has not been included in that evidence-based, though I have written gabapentin also and pregabalin continuous release and duloxetine. If it is, especially for the overweight osteoarthritis patients, duloxetine turns out to be a very good choice, because it,
Thiocolchicine.
Thiocolchicoside or tolperisone, whatever you feel like, both are available in the market, and in combination with paracetamol, and alone also they are available.
But I want to add one thing. If we follow the American College of Rheumatology guidelines, what is given, anybody has read that guidelines, what is the treatment for the osteoarthritis of knee? The first is the medical management, second is the physical therapy, third is if wet knee, if there is a synovitis or suprapatellar bursitis, they recommend single shot intraarticular steroid. In that, they recommend more triamcinolone hexaacetinoid, not the triamcinolone acetinoid. They are giving triamcinolone hexaacetinoid, which is having less chondrotoxic effect. The single shot, not more than 3 shots of steroids in a year. It's a biased mindset that one should not go for the steroid at all. Whenever there is a moderate effusion, you have to tap it, send for the cytology. If it is non-infective, you have to give the triamcinolone hexaacetinoid. Only 40 mg is required. If you are using plain acetinoid, you might require 60 mg. But if hexa you are using, it's a low dose. And then once the inflammation is over, then I recommend hyaluronic acid. I'm a strong believer that advanced ONE, where everybody said since yesterday, these therapies, all regenerative therapies are applicable to grade 1, 2 and early grade 3. And we are talking about the advanced ONE. So my recommendation is that, and this is in the American College of Rheumatology criteria and guidelines, the hyaluronic acid under vision you should inject, under ultrasound guidance. There is a disparity in the evidence. Those orthopedicians have given blindly, and the specificity and sensitivity is very high when you are giving with ultrasound guidance. So I recommend 6 ml of Synvisc 1. I don't use any other, this thing I'm not promoting any company, but I got very good results. I don't believe on 2 ml every week, 3 weeks you come, only 6 ml single shot after the inflammation is over, and patient has to repeat it before 6 months. Means that is very important. One hyaluronic acid injection is not going to help your advanced ONE patient. We have to give it again before that lubrication action is over. So then you can go for the yearly or 2 yearly injections. Or I have treated with the hyaluronic acid advanced ONE Dr. Bhoite, who is the physician of Baramati. 10 years back, he used to take the ICHA injections 1 yearly initially. Since last 6 years, he has never received any hyaluronic acid injection. He is absolutely fine. His X-ray is improved. So the important is that we have to follow the protocol.
Okay, so about the steroid injection, one last question, because you have mentioned about the steroid injection, about the hexokinase. So what is the time duration, minimum time duration between your steroid injection if you have to re-administer the steroid?
I never re-administer, only one. Only once. In my lifetime, I never re-administered. Only one time I administer, and I don't feel hesitant to administer whenever there is a moderate
Even
effusion.
if that injection has helped for some time, you don't take that as it has not helped. Still you
Pardon?
don't. Even if that injection intraarticular steroid has helped the patient and pain has come back, which means
No,
it has helped.
That's why I told you na, that you should tell the patient once you have received the 1 shot of steroid na, within 6 weeks, means after 4 weeks and before 6 weeks, you should come for the visco supplementation. If you are not willing to come for the visco supplementation with the hyaluronic acid, you have to go for the pulse therapy of analgesics or long-term neuropathic medications.
So you don't advise to go for the repeated steroid injection,
No,
whatever
no,
may be
no.
the time gap.
I support them with this teriparatide one. This bone density should be, and actually they are giving really good results with teriparatide. Subcutaneous 20 units every day for 18 months, but mostly I stop it before 1 year. Because there are the side effects of teriparatide or denosumab, you can go for that. And support the patient with glucosamine, chondroitin sulfate and neuropathic pain medications. And if at all there is a re-inflammation of the joint, you have to support with this diclofenac, ceratopeptidase and muscle relaxant combination. We have to give it, and we have published a paper on the COX-2 inhibitors and curcumin, which we received the best research award in global updates in Chicago. Because whenever you are using long-term COX-2 inhibitors, there is a chances of thrombotic incidences, means stroke and myocardial infarction. People are hesitant to use the COX-2 inhibitors because of that. We add it with the curcumin, which is haldi product. So it is a natural blood thinner, and this is the thromboxane A2. There is an imbalance between prostaglandin and thromboxane A2. We have written in that paper. That is really helping, but that is the pulse therapy. Not every day. Whenever you get the pain, you can take with the proton pump inhibitor and curcumin.
Okay.
So that is my strategy. Those who are not affording any kind of regenerative therapy.
That's a good valid point. I think we have come to the end of this excellent discussion. I think a lot of inputs has been given by the panelists and from the chairpersons like
Thank you so much for everyone for patient hearing. Have a wonderful day.
Thanks to all our panelists for this wonderful session. So now, I would like to request Dr. Sameer sir to felicitate Dr. Anand sir and Dr. Kiran ma'am. So with this, we come to the end of the sixth session. We now move on to our next session. So to start our next session, the first topic is role of cryoablation in pain medicine by Dr. Gautam Das sir.
So before going to start the next session, I would like to announce the winner of this e-poster. So for announce winner of the e-poster session, I would like to call the judges of the e-poster session. Judges were Dr. Soikat Niyogi sir and our present president. Sir, please. Judge. So that they can announce the winners. Sir, please announce.
Thanks to all participants who are participate in the poster presentation. Everyone has good presentation, but according to our judgment, we give some points to them. First of all, I call the Dr. Priyanka to come on the stage.
Dr. Priyanka and Dr. Sheetal Gaikwad.
Dr. Sheetal Gaikwad. Both are acquired second position jointly. They get 40 out of 50. Okay.
I'm Dr. Priyanka.
Any
I'm the fellow
representative is
from
there,
Daradia
Dr.
Pain
Gaikwad?
Clinic, Kolkata. My topic was retrospective analysis on pain outcomes, comparative study between the radiofrequency ablation versus cryoneurolysis of sacroiliac joint in chronic sacroiliac chronic sacroiliitis.
So a big hand for this.
Dr. Sheetal Gaikwad.
Sheetal.
Anybody known can take?
And the first prize goes to Dr. Shumit Kumar Singh. Dr. Shumit Kumar Singh, Garden Ridge, BNR Hospital. She gets 41 out of 50.
Okay, thank you.
Hello. My topic was pulsed neuromodulation of the three nerve of the shoulder joint along with hydrodistension of glenohumeral joint for adhesive capsulitis. We had a case series of above 60 to 80 cases. So we have sent it for publication also.
Thank you.
Yeah, that's the one. That's the one. The next one. Yeah, yeah, that's one. I'll tell you one thing. I'll take these ones. Where is that? Where is my? Which drive? Which drive? Huh? This is the last one, na? Let's remove it. It will show. Let's put it back in. E is our driver, right? E is my drive. I will take. No, I actually asked Priti Doshi that I'll take the call. Copy. Huh? E, right? This one? And this one. This one. Excellent. What's next for you? Hey, just show me that one. I think presentation. Where are the presentations? PPTs? PPTs. मेरा तो आ गया. Previous one. सुबह का और कुछ है तो अच्छा वाला मैं ले लेता हूँ या PPT. कृष्ण जी के कुमार. इसके पहले कुछ है? हाँ? No, carry on. No, I've taken mine. No. No.
Sir, you can copy there.
हो गए.
So our next session going to start, please.
So for our next session, our chairpersons are Dr. Chandan Kumar Pal, Dr. Shaista Tabassum, Dr. Lieutenant Colonel Mohit Katarokasa. Dr. Mohit. Over to Mohit, sir.
So, very good afternoon. Now I request Dr. Gautam Das sir for his speak. Gone. Next speaker is Dr. Gargi Nondi. Her topic is prolotherapy, the forgotten hero. So, she is at ASI Institute of Pain Management. And her area of interest is the chronic pain, intervention pain management, and cancer pain. So over to you, ma'am.
Okay, a very good afternoon to all of you. I would like to thank Dr. Krishna Poddar Madam and Dr. Shomir Washak for organizing such a beautiful conference and inviting me. Since yesterday we are talking about the different modalities of the regenerative therapy, but I think this dextroprolotherapy did not get any chance to show its magical effect. So the prolotherapy is really a forgotten hero. I will talk about the prolotherapy today. Now what is the prolotherapy? The term prolotherapy derives from the Latin word prolos, means growth or offspring. So by definition it is a type of therapy that involves injection of an irritant solution into joints, tendon or ligaments to spur an inflammatory response that can expedite healing in damaged tissue. So a little bit of history. Almost 1350 years before Christ, the earliest form of prolotherapy was used by the Egyptian to treat the animals by branding or hot iron cautery. And 400 years before Christ, the first recorded use of prolotherapy in humans was by the Hippocrates, who used a hot poker in the axilla to repair a dislocated shoulder. And in 1835, Alfred A.L.M.L. Velpeau, who was considered the father of the prolotherapy, injected a patient with an iodine solution to treat a hernia. So previously the prolotherapy was used to treat the hernia by a group of physicians who were called the herniologists. Then came the Earl Sage Gedney. He was an orthopedic surgeon, and he got an injury in his hand by the door of the surgical suite, and to stabilize his injured joint and to reduce the pain, he used those sclerotherapeutic agent in his finger, and that reduced his pain. And in 1937 he published the hypermobile joint, the first known article about the injection therapy. Then it was called the sclerotherapy in the medical literature, and this article gave a preliminary protocol and two case report, one of a patient with knee pain and another with low back pain. Then 1939, after 20 years of patient care, Hackett proposed that injection of proliferating solution could help strengthening weakened ligament or tendon, and he first coined the term prolotherapy. And he published the first formal textbook on this subject titled Ligament and Tendon Relaxation Treated by Prolotherapy. In 1961, he founded the Prolotherapy Association. So what are the proliferants? Means what are the solutions we can use as a prolotherapy? First is the osmotic agent like the 10 to 25% dextrose or glycine. Then the agents that attach to the cell wall and stimulate growth, that is the dilute phenol, urea, ozone, tannic acid, like that. Third is the chemotactic agent, that is the sodium moreuate, a fatty acid derived from cod liver oil, and some cofactors which we can inject as the adjuvant like the magnesium, manganese, zinc, vitamin C, growth hormone, glucosamine sulfate, like that. So the most commonly injected material used in prolotherapy is hypertonic dextrose. It may be 10%, 12.5%, 16.5%, 20 and 25%. I normally use 12.5% dextrose for the prolotherapy, and this is very much irritant, so the injections are diluted with local anesthetic. Second is the sodium orate is composed of 2% benzyl alcohol and the sodium salt of cod liver oil. Third is the DPG solution, that is the dextrose phenol glycerin solution consisting of 25% dextrose, 25% glycerin and 2.5% phenol. Again these are diluted with local anesthetic. Third is the ozone. The concentration of the medical use of the ozone is 10 to 20 microgram per ml. Okay. So next, what are the differences of regenerative therapy versus prolotherapy? Actually, the prolotherapy is the type of the regenerative therapy. Under the umbrella of the regenerative therapy, apart from the prolotherapy, there are stem cells, platelet-rich plasma, adipose tissue-derived biologics, like so many things which we are discussing since yesterday. So what are the difference with these therapy from the prolotherapy is using the PRP or other thing is like adding fertilizer to a newly planted seeds versus just planting the seeds. That means when we are using the prolo, it just induces the inflammation. But when you are using the PRP or the stem cells therapy, then we are using the growth factor also. So when we are using PRP like that, it is like adding the fertilizer. Okay, and the condition of the soil, that means the condition of the joint, cartilage or the tendon is very much important to determine the formula, which formula is best best of the choice. Okay, so the condition of the soil is very much important. Now what is the mechanism of action? At first we have to know the natural healing process of the tissue. After any injury, there is 1 to 3 days it generates the inflammation. Then up to the 2 weeks it is the proliferative phase, and up to the 2 years there is the remodeling phase. At first there is the coagulation, then platelet and fibrin actually acts. Then the inflammation, where there is the neutrophil and lymphocyte, and at the proliferation state there is the fibroblast proliferation, scar formation, collagen synthesis, like that. So if we see the biology of the prolotherapy, it actually induces the inflammatory cascade. Okay, by releasing of growth factor by the mesenchymal stem cell, it modulates the action of the TRPV1, which is responsible for the neurogenic inflammation. It inhibits the expression of the metalloproteinase by blocking the interleukin 1B activity, thus preventing the degradation of the collagen. It increases the release of TGF beta, PDGF receptor beta, TGF alpha and FGF, and induces the fibroblast and the chondrocyte proliferation. And it increases mRNA expression and production of the inflammatory markers including COX-2, interleukin 6, interleukin 8, PGE2, and a decreased TGF beta 1 secretion. That's why the prolotherapy is called, it is a controlled inflammation. Okay, we are generating inflammation but in a controlled way. Okay, so what are the main indication? First is the tendinopathies, like the tendoachilles tendinopathy, tennis elbow, patellar tendinopathy, and the tendon is injured mostly by the repetitive motion or the overuse injury. Then the Osgood-Schlatter disease, temporomandibular joint syndrome, plantar fasciitis, groin pain, mainly due to osteitis pubis, and the adductor tendinopathy, most commonly seen in the rugby, soccer player, also in the football players also. And then the shoulder joint pain due to the rotator cuff injury. Then the osteoarthritis and the degenerative conditions, and there is a strong level 1 evidence for the knee osteoarthritis or the finger or thumb osteoarthritis. It can be used in the SI joint pain and the chronic cervical, thoracic or lumbar pain. And it is a level 2 evidence in the myofascial pain syndrome. So when we administer the prolotherapy to the patient, at first evaluate the patient. Take the patient history, physical examination, and review the previous studies, the condition of the ligament, joint, like that. I told that the soil is very much important. So if there is excessive degeneration and there is a moderate tendinosis and the muscle tear, high grade muscle tear, then the PRP or the other type of regenerative therapy will help. But if there is average type of the injury, of the tendon injury, then we can try the dextrose prolotherapy. So it is very much important what are the post-procedural advices. So prescribe only acetaminophen and or narcotic for the pain. We cannot give the NSAIDs because again we are generating the inflammation. If we inhibit the inflammation, then there will be no effect of the prolotherapy. Also we tell them to avoid the cold compression sometime. Okay. Then rest for at least 2 to 3 days. Injection interval are typically spread over 4 to 6 weeks apart and the frequency 4 to 6 normally. Most patients do not see result until after their second or third treatment. So counseling is very, very much important. Okay. And if no improvement are seen following 3 prolotherapy sessions, alternative intervention should be considered. Okay. So it required multiple injection. So before giving the injection, counseling is very, very much important. And the events following prolotherapy. There was immediate pain relief due to the local anesthetic. After the few days, there is increased pain due to the inflammation. So again, there is a role of counseling. You are injecting some solution to reduce the pain, but it is increasing the pain. So the patient, there is compliance may be poor. So before giving the injection, you have to counsel the patient. And there is a decreased pain after the few days, and after there is mild increase of pain in the 3rd or 4th week, it is called the window period, and the prolotherapy is repeated at 6 weeks. So what are the contraindication of the prolotherapy? That is the allergic to the anesthetic or the pluripotent, acute arthritis, bursitis, tendinitis, gout, or complete rupture of a tendon or ligament. As I told, if there is a excessive degeneration, then we cannot give the prolotherapy. There will be no result. If there is active infection, cancer, or any other underlying conditions that may prolong the healing process or leave the patient immunocompromised. And the relative contraindications are regular uses of corticosteroid or NSAIDs and the long-term use of narcotics, because it again decreases the immunity. And what are the side effects? Normally prolotherapy is very low risk procedure and the complications are extremely rare. Only the soreness and swelling at the site of the injection after treatment, which usually disappear within 1 to 2 days. It may cause bruising, headaches, allergic reaction, temporary numbness, nerve irritation, and infection. So there are some evidences. In the 2024, the paper was published. It is a systematic review of RCT of prolotherapy in the treatment of sports-related tendinopathies, and they showed a promising result. Okay, next, in this study, the dextrose prolotherapy used for the chronic tendinopathy, and again it improves the symptom of the patient and with no adverse reactions. Here they use the dextrose prolotherapy again on the tendinopathy, but in this study they showed there is insufficient evidence to support the clinical benefits of the dextrose prolotherapy. Here the prolotherapy is used in the rotator cuff tendinopathy, and here also it is showed that it has a potentially effective adjuvant intervention to physical therapy for patient with rotator cuff tendinopathy. This is a systematic review to show the efficacy of the prolotherapy for the osteoarthritis, and they concluded that dextrose prolotherapy in osteoarthritis confers potential benefit for pain and functional outcome. This is a meta-analysis of the systemic review and meta-analysis for the dextrose prolotherapy in knee osteoarthritis, and they again concluded that prolotherapy in osteoarthritis confers potential benefit for pain, but the studies are at high risk of bias. Then again, this is the paper on the prolotherapy for the treatment of the osteoarthritis of knee, and they have administered 3 to 4 injections approximately 4 weeks apart, and by the 8 weeks improvement in VAS and other subjective outcomes are noted. And this is a randomized control trial to evaluate the efficacy of the intra-articular hypertonic dextrose, that is a prolotherapy for knee osteoarthritis, they also concluded that it reduces pain and improve functional quality of the patient, but and it is very much safe. This paper shows the satisfactory outcome of the symptomatic SI joint instability, and here the use of the prolotherapy, it reduces pain. And this is again a paper on the prolotherapy over the sacroiliac joint, and the intra-articular prolotherapy provided significant relief of SI joint pain, and effect lasted longer than those of steroid injections. And this is a paper to see the efficacy of the dextrose prolotherapy in elite male kicking sports athlete with chronic groin pain, and they concluded that it showed marked efficacy for chronic groin pain in the group of elite rugby and the saucer player. And this is for the USG guided prolotherapy for the athletic pubalgia, and it also showed the favorable outcome. This is a retrospective case series where they use the dextrose injection for the treatment of the chronic myofascial pain. Okay. So now why it is relevant till today? Now we are talking about so different types of the regenerative
Ma'am,
therapy.
please conclude. Your time is over.
Just 2 slides only. Okay. Why why it is relevant till today, and this lecture is placed here because in our 2020 study from the World Economic Forum found that some 220 million of Indians sustain on an expenditure level of less than rupees 32 per day. So we can easily see the how many of people are below the poverty line, and the 100 ml of dextrose cost only rupees 25, and it is actually effective. So I think prolotherapy is till now very much relevant to treat those musculoskeletal problem, or as a under the umbrella of the regenerative therapy. And we never forgot your roots, and always be proud of where you came from. So the starting of the regenerative therapy started with this type of prolotherapeutic agent, that is the dextrose and all. So I think we should not forget the prolotherapy, and we should practice this. So the prolotherapy should not be the forgotten hero. This is relevant till now. Thank you.
Thank you, ma'am. Very well presentation.
Thank you for your good presentations. Can you show some light on what is the percentage of the dextrose needed intra-articular, intramuscular plane, or around the nerve? Because this concentration matters a lot. The dextrose injection is a double-edged sword. It has the pro-inflammatory effect in certain concentrations. It has the anti-inflammatory effect on certain concentrations. There is no clear-cut line of these things. Below this level, it acts as a pro-inflammatory. Above the level, it acts as an anti-inflammatory. To know about for which condition you are using, suppose in severe OA, the whole world is crying against the steroid. My immediate next choice is the dextrose, which I can boldly inject it. And even with the sports persons are coming to us, which we cannot inject the steroid. It's highly restricted for them. The next choice, before jumping into the any PRP, something like that, this prolotherapy plays a major role. So you have to know that at what concentration we have to give that, and for what indication you are give that. Yes. Most of these prolotherapies, even though it is named delayed,
yes.
So any patient comes with hyperacute pain, they will have some kind of that pain, immediate pain relief is needed, whether the sports injury or the degenerative injury. So severe swollen knee is coming. At the same time, one person have the tendon strain or muscle strain is there. Both have very severe pain that. So in that conditions, the good choice is the dextrose. So if you want to give the dextrose things, I want to have that inflammatory, anti-inflammatory effect of this dextrose rather than the pro-inflammatory effect. But both the things are going to be happen at what concentration you are selecting that. There is a good person, the William Murray, whoever wants to have more knowledge about this prolotherapy, what concentration done, better to read the articles from the William Murray. Is the master in prolotherapy, and I had the great opportunity to bring him our own platform lecture, and I had the lecture also there. So in guidelines are anything around 15% it will act as a anti-inflammatories. Anything around 5% will act as a pro-inflammatories. So anything between these two will have the dual actions. So if you want to give articular injections, we'll go maximum 20% or 15%. If you want to give anything interfacial plane, muscular thing, we will keeping around to 10% to 7.5%. If you want to inject anything in around the nerve, restrict around 5%. This is the great rough guideline given by William Murray, and it works well. So the prolotherapy will be the game changer. Yes, it is a game changer. And those who wants to avoid the steroid in their practice, it really does lot of wonder. It's
And
a very good lecture. It has to be put on the first day, not on the last of the day. Thank you very much.
And sir, actually in my practice sometimes I also combine the dextrose with the ozone also, and which I observe it gives a better result.
Thank you, ma'am.
Sir, actually.
Again, the ozone is the controversial one. Why the ozone is there? It may work. It won't cause any side effects other than that. So we can't use the ozone legally in all cases, because we are living in the world of legality also that. So simple dextrose also will makes a lot of these things.
In the knee
Clinical evidences.
osteoarthritis, actually, we normally use the 12.5%, and sometimes it increases pain after the 1 and 2 days. And if we mix the ozone, that pain goes some amount, it reduces the pain.
Sure.
So
Thank you, ma'am. Due to lack of time, we next shift to the next speaker. Next speaker is Dr. P. Mahajan. Is he here? No. Okay. Next speaker is Dr. Shamir Bashak. So his topic is medical ethics and regenerative treatment.
Thank you, respected
Dr. Bashak
chairperson.
does not require any introduction. He is presently working at Central Hospital, Southeastern Railway, and his area of interest is chronic pain and regenerative medicine. Over to you, sir.
Thank you, respected chairperson, Dr. Mohit. So this topic was being kept as we have to get credit point. But when I start reading the medical ethics and about the regenerative medicine, we have seen that it is not about credit point, and medical ethics is an integral part of every doctor for their everyday working. And medical ethics is not in medical curriculum, because we have huge syllabus in MBBS course, MD course, so many course. So we don't have any space for this medical ethics. So we shortly going to demonstrate about the medical ethics and regenerative medicine. It is the patient and physician relationship. It is developed from the home, not at the college. It starts developing from at the home. And guideline as per World Medical Association Medical Ethical Manual in 2015, they have set medical ethics in modified form, but it started in the 2000 year back, when one case scenario, Mr. R, general practitioner from rural town, started one trial over new NSAID for osteoarthritis, and she offered a sum of money for each patient that she enroll for the trial. So she is happy, never participated in this kind of trial. So if also get opportunity to take extra money, she accept this and take this for trial. This one case scenario. Dr. C is a anesthetist in a hospital where one senior surgeon is very rude behavior in the OT room. He use outdated technique for prolonged operation and leads to greater post-operative pain, longer recovery time. Not only this, but also he make crude jokes about the patient during the OT, also about the nurses. These are two case scenario. Here anesthetists and nurses want to give complaint in the higher authority, what they will do. So regarding this, keeping this two case scenario, so it is the not about the scientific and technical question, it is about ethics, physician behavior and the decision making. The question is here. So ethics is the study of morality, careful and systemic reflection of analysis of moral decision and behaviors. Morality is human decision making behaviors actually. And bioethics comes when we use this type of regenerative medicine, this time biomedical science. It is a very broad subject concerned about the moral issue by the development in the biological science more generally. So why we do study? Because it is not written in the book, but it teaches us how to handle difficult situation, how to deal them in rational way and principle manner. So chapter 1 in this World Medical and Manual of the Ethics, they have written that principal feature of medical ethics, there are 8 chapters. I am going to describe only one chapter. Relief from the pain and suffering and restoration of the health and well-being. So people come to the physician for this help, and they allow the physician to touch and manipulate their every parts of their body and even their most intimate parts. They do this because they trust their physician to act in their best interest. And today what happens, most physicians feel that they are no longer respected as previously they were being respected. So there are expectation and gap. So in order to meet the expectation, both the patient, student, physician, it is important that the physician know the core value of medicine with compassion, competence and autonomy. Compassion is as understanding and concern about the one person's distress. It is essential for medical practice. And he should be competent enough, both expected competence and required by the physician. Lack of competence can result in death and serious morbidity in the specific subject, also in the specific intervention. And autonomy is both patient explain everything to the patient, let them decide what they want to the procedure. Or physician autonomy means physician decide what he wants to do for the patient. So there are two types of autonomy, the patients and physicians. Okay. There we should be adherent about these 3 core values as per World Medical Association Declaration of the Geneva, which was started by Declaration of Geneva. What is this declaration? This declaration we generally don't read in our medical curriculum. It is like that: I solemnly pledge to concentrate my life to the service of humanity. I will give to my teacher the respect and gratitude that is their due. I will practice my profession with conscience and dignity, and health of my patient will be my first priority. I will respect the secret that I confine to me even after the patient has died. Somebody also noticed, we have seen that somebody explained in the WhatsApp media that he was my patient, now he is doing that. So we should not disclose this patient name and some disease. I will maintain by all the means in my power the honor and the noble tradition of the medical profession. My colleague will be my sisters and the brothers. I will not permit any consideration for age, disease, disability, gender, race, sexuality. I will not divide any patient with this. I will maintain the utmost respect for human life. I will not use my medical knowledge to violate human rights and civil liberty. I will make this promise solemnly, freely, and upon my behavior. Honor. So, ethics is pluralistic. Who decide what is ethical? Here, the human rights is right to my life, right to freedom from discrimination, torture, cruel, inhuman, degrading treatment. Human rights especially important in this medical ethics. To freedom to opine and express, to equal public service of any one's country and medical care. At global level, World Medical Association set the ethical value, but in most countries there are medical association, different bodies. They develop the ethical standards and this practice as per their medical law and standard. So, does medical ethics change from the country to country? Until recently, physician had the right and duty to decide how patients should be treated. As per World Declaration, the right of the patient begins in this statement that relationship between physician, their patient, broader society has undergone significant change in recent time. Until recently, physicians generally consider themselves accountable only to themselves, to their colleague, to the medical profession, for their religious behavior and to the God. Nowadays, they have additional accountability to the patient, to the third party, to the hospital management, healthcare organization. So they are accountable to so many bodies. And despite these obvious changes, medical ethics, there are widespread agreement among the physicians that the fundamental value, ethical principles of medicine don't, or at least should not be changed. Like euthanasia, some country it is acceptable, some country it is forbidden. That is the condemn, in others, like at least in the royal it is accept. So medical ethics differ from country to country. The role of World Medical Association has undertaken the role of establish general standard of medical ethics that are applicable to the worldwide. They first changes updated the Hippocrates Oath. Second, they updated the International Code of Medical Ethics in their General Assembly during 1948 and during 1949, and gradually they are updating. So ethical guideline on human research depends upon the declaration of the Helsinki. So Helsinki declaration is that while the primary purpose of medical research is to generate new knowledge, and this goal can never take precedence over right and the interest of the individual research subject. How does the medical decide what is ethical? So if there is any new study going on, or then should be their vote. They ensure 70% vote more favor, then they decide, World Medical Association, that it is ethical. Regarding the musculoskeletal regenerative medicine ethics applicable, yes, it is quite obvious. So there are so many publications, ethics in musculoskeletal regenerative medicine, guidance in choosing appropriate treatment and trial. So this allogenic stem cell should inject at what stage, and what stage is ethical, and what control trial should we use. So how does ethics committee do approval this kind of treatment, stem cell, orthobiologics, bone marrow? So there are regenerative medicine umbrella is cell-based intervention, biomaterial implantation, gene transfer, tissue engineering. And there are 4 stages of if we take 4 stage of disease, invasive procedure leads to early stage, the prevention in the late stage, early stage in the, there is a risk of the disease, then early stage. Intervention require only in the middle stage or in the when early stage over, then intervention indicated, and later stage with severe symptom only conservative medicine is indicated. So at the early stage, at risk, our objective of intervention is the prevention. At the early stage, objective is to return to the healthy state or slow the progress of the disease. Or in the early stage is it is substitute of surgical treatment or supplement the surgical treatment or postpone the surgery, and the late stage aims slowing the disease. So all intervention is not indicated at all stage, it is not also ethical. As you see, prevention is required at the early stage, then in the return to the healthy life. Surgery in the, when middle stage we can substitute the surgery or postpone the surgery or improve the surgical outcome, or later stage only the prevention of the progress of the disease. So mesenchymal stem cell for bone repair, also this ethical value defined, that stem cell, as already throughout the class discussed what is stem cell, all three germ layer, pluripotent. Human embryonic cell is the pluripotent, but it is applicable to regenerative medicine, but most important thing is that malignant neoplasm or teratoma, when we harvest, and legal implication. These are most two important things. And adipose tissue, adult stem cell, this type of problem is lesser. Teratoma formation or legal issue is lesser. But fractional mesenchymal stem cell quantity is less. It is currently US FDA approved bone marrow as per this guideline. Another ethical safety issue, cell-based therapy demonstrated that teratoma formation is, this picture demonstrates that if we use embryonic stem cell, chance of teratoma formation is more, because they can differentiate at any cell type, ectoderm, mesoderm or endoderm. On mesenchymal stem cell and cell-based therapy, when you use this, International Society for the Cellular Therapy had formulated to that plastic adherent potential for differentiation, that they have chondrogenic, osteogenic and adiposogenic, and their cell expression, as already Cell told, CD105 and something etc. And this type of cell, adult mesenchymal stem cell, has lesser differentiation potential, lesser chance of tumor growth by angiogenesis than embryonic stem cell. In this way, we have ethical, if it is required in the middle stage of the disease, we should use adult human stem cell, not embryonic stem cell. And these are origin from bone marrow, umbilical cord, adipose tissue, and there are so many applications other than this. We have seen the regenerative medicine only for this is also inflammatory bowel disease indicated, end stage liver disease, promising result also in cardiac disease, not only in musculoskeletal regenerative medicine. So we have to take care of this, think about the tumor growth and metastasis. Chance is lesser with this adult cell-based therapy. This safety issue is more with this adult mesenchymal stem cell than human embryonic stem cell. One study was done in the eye, and ultimately result was that he lost the both eye due to blindness. So this type of complication we have to keep in mind while application of the mesenchymal stem cell or any cell-based therapy. New research should focus on definition of the factor signaling pathway that are responsible for the fate of mesenchymal cell after their administration. What kind of differentiation they go after inserting into the human body. This is so mesenchymal stem cell are widely used human remedy. We should use judiciously and ethically. These are my references. Thank you.
Thank you very much for your nice talk and within time. So I request any questions from the house. So thank you very much, sir.
Thank you, sir. I would now like to request Dr. Krishna Poddar ma'am to please come over the stage and felicitate Dr. Mohit Kataruka sir, Dr. Shomit sir and Dr. Gargi Nandi ma'am.
Two more online session is there.
एक चला
would like to request Dr. Samir sir to please felicitate Dr. Krishna Poddar ma'am.
So thank you all the esteemed dignitaries, all the delegates, faculties. Thank you all for coming here and participating in the conference actively. Thank you all the company person. Thank you all the other organizers, all the hotel management. Thank you all for active participation. Our OT staff, our dresser brothers. Thank you to all for organizing this conference and making it successful one. One session is due, that is online session. Online, we'll continue this online session for live streaming for YouTube, for VR Ravi Kumar.
A great round of applause for Krishna, Samir and Sumit and the whole organizing team. Hip, 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 hip.
We will meet again.
We will meet again next year.
We will meet again next year.
Yes, with more innovations.
With more regeneration.
With more regeneration. I don't know what will come that time.
Thank you, Stella. Thank you, Nityanand. Nityanand, the behind person, but very important. কি করবে নিত্যানন্দ সেশনটা চালাবে না? চালিয়ে দাও দুটো 15 মিনিট করে আধ ঘন্টা চালিয়ে দাও না, চালিয়ে দাও না, এটা অনলাইনটা চালিয়ে দাও, অনলাইন চালিয়ে দাও, দুটো চালিয়ে দাও।
approved in India. They still think it is a form of research, but it is already patient's own cornea, they took the limbal stem cells and applied it for corneal blindness through the company called Reliance Life Sciences. So this was available since 2014. Similarly, now the allogenic bone marrow derived stem cells are approved for Burgess disease, though it is available since 2021. It was approved in 2017, and since then the diabetic ulcers, non-healing ulcers, osteoarthritis, and other indications like for skin regeneration, hair regeneration, and under eye dark circles, the conditioned medium derived from allogenic bone marrow stem cells are available in the market. So apart from that, there are a couple of gene therapy products as well as the immune products, but our focus is on the stem cell products, mesenchymal stem cells. So this is another company, Regrow Biosciences, which has got 3 products: Osgrow, Cartigrow, Urigrow. Osgrow is for bone, where you take a biopsy of the bone, send it to the company, they will culture it and send it back to you within 3 weeks, around 50 million cells. Similarly, for the cartilage, in cartilage regeneration, and for the mucosal regeneration of the urethra, less than 4 centimeter strictures, you can take the biopsy from the mouth, from the buccal mucosa, send it to them, and they will culture and give it back within 3 weeks, which can be injected for stricture urethra. So these are some of the products which are available not only in orthopedics but also in other specialties. So this is the approval letter. You can see the date of approval: 2017, 2020, 2022 for the TAO, CLIPAD, and osteoarthritis. So now any orthopedic surgeon in India can prescribe these stem cells, get it in their clinic, and use it for their patients for a particular indication. Worldwide also there are other stem cell therapies which are approved in Japan for Crohn's disease, GVHD, and for the first time for Parkinsonism, a neurological disease. They have got approval, 5 doses, intravenous and intrathecal, and the approval came in 2023. Europe and South Korea also have got 2 products, but it is India which has got 7 products. So this is the product for osteoarthritis called Stem 1. So this vial contains 25 million allogenic bone marrow derived mesenchymal stem cells. So the company has done all the animal trial as well as the human trial, and then come out with a product after phase 3 trial for grade 2 and grade 3 osteoarthritis. And there is at least 1 year pain and stiffness reduction, and the cartilage quality is maintained. Volume is maintained for 1 year, whereas in untreated there is a decrease in cartilage volume with minimal side effects, and the 2-year data is also awaited. But we have been using it for autologous for our patients for more than 10 years. So this product Stem 1 is obtained from 3 people, from 3 young adults, taken from the bone marrow, and you can make it into 1 million doses, and it can be used for osteoarthritis, which already the approval has come, and other indications. These are pending. Next year probably we will get these approvals. So osteoarthritis, as I said, we have been doing autologous. So this is our very early case where you can see we used autologous patients' own bone marrow concentrate and injected, and within 7 months you can see an increase in the cartilage height, and that is possible only in age group of 55 to 60 years. So another case you can see another 54 years old female where the cartilage, not only increase in the cartilage volume but also the quality of the subchondral bone as well as the articular margin. Osteophytes disappear as well as the articular margin becomes clear. So how long the effect lasts? So you can see that if the patient reduces the body weight, if the patient is doing all the exercises properly, not putting on more weight, you can see up to 48 months, up to 4 years, the cartilage, initially there's an increase in the cartilage volume, and as the patient walks for the next 4 years, again comes back to the same stage. So for 4 to 5 years, you can have a sustained relief of pain, and probably after 4 years, 5 years, we may have to do a booster dose. And still many people don't realize that cartilage can be regenerated, and there can be an increase in the cartilage volume, which is shown by MRI. This is from another group which has done adipose derived stem cells, and they have demonstrated the increase in the cartilage thickness in an MRI. It's not only the thickness, you can also see here also there is an increase in the cartilage thickness, but it's not only the thickness, but it is also the quality of either the cartilage or the cruciate ligament or the meniscus, whichever is injured inside the knee joint. So here is a histogram. So this in MRI you have gotten artificial intelligence software which can show that the increase in the quality of the cartilage by comparing the injured one and the healed one. If there is a shift to the left, then the quality of the soft tissue is much better. Here also you can see a partial injury healing well, and then there is a shift to the left, and this shows that the collagen quality has improved and the healing is better, scarring is much less. So this is again for a meniscus where they have with autologous PRP, they have shown pre and post injection the meniscus has healed within 6 months. So the orthobiologics, whether it is the platelet rich plasma or the bone marrow derived stem cells or fat derived stem cells, in some cases they are able to regenerate the musculoskeletal tissues like bone, muscle, tendon, cartilage, and that is why orthopedicians, dermatologists, sports physicians, and plastic surgeon diabetologists, they are avoiding amputation. They are recreating the collagen, this collateral circulation in cases of a diabetic ulcer. Similarly, gynecologists for infertility and ophthalmology. So these are the people who have already started using orthobiologics. So thank you. So with the help of the other specialists also, we will be making more strides and bringing this revolution of regenerative medicine applicable to all of our patients, irrespective of their specialties. Thank you.
Good morning, good evening, everyone. This is Dr. Charan Ganta. I'm a senior scientist at the National Institute of Environmental Health Sciences at NIH, which is a part of NIH. I'm also an adjunct professor at Kansas State University. I primarily work in the area of regenerative medicine, understanding the immunomodulated properties of mesenchymal stem cells and also the antimicrobial properties of platelet-rich plasma, mesenchymal stem cells, etc. So for the topic today, I'm going to talk about the potential variables affecting the PRP outcomes. And I would like to thank the conference organizers for extending this invitation. Before further ado, let's get into the topic. The word orthobiologics means healing by use of biological substances that are naturally found in our body. It can be autologous or the allogenic. As you can see in this last decade, there are several orthobiologics in use. Amongst them, platelet-rich plasma, also popularly called as PRP, has gained a lot of prominence. In the last decade, there are several publications on PRP and osteoarthritis. But unfortunately, a lot of these publications lack adequate reporting of preparation methods or the PRP composition, like how much of platelets are present in that. Hence, these studies are not very well reproducible, and the outcomes also cannot be properly verified and highly variable. It is also shown that it is published by Nature reports that approximately 50% of these published research is either flawed, and a quarter of them you can't even trust the data. So again, this much amount of variability is mainly because how the PRP is being prepared, and not understanding all the variables can significantly affect the outcome. So today, that is the topic I'm going to talk about. How do you optimize your therapeutic outcomes of the PRP? There are like million ways to prepare a PRP, but there is only one way to prepare PRP with a good therapeutic potential. First of all, you need to understand the variables. The patient's variables, PRP procedure methodology is another variable, and how the physician's approach to the problem is another variable. I want to discuss some variables in each of these areas. Coming to the patient factors, here is a list of patient factors. With increasing age, there is a decrease in the number of platelets, and it is known that is more platelets is more growth factors. So in order to achieve good therapeutic dose with in a patient who is much older, you need to start with more blood, and we probably need multiple PRP doses as well. But again, sex seems to be play no significant role in the PRP therapeutic outcomes. And then with the diabetes patients, these patients tend to have increased platelet reactivity. It's mainly due to increased blood glucose levels, and also they have a constant low inflammatory state. All of these cause hypercoagulation and more platelet activation and release of these growth factors. So by the time you're making the PRP, you're not able to concentrate the growth factors in the platelets. So when you spin it up, all the platelet gets activated and the growth factors gets released into the plasma fraction. So you're not really getting any PRP that is rich in growth factors, because your plasma fraction is the one that has all the growth factors. You're ultimately losing the growth factors. So same thing applies to the patients with obesity and hypertension as well, where there is chronic activation and loss of these platelets. Again, coming to people like who are eating this the patients with a diet that is that they consume with like rich in fatty and sugar diets also tend to have increased platelet reactivity. As you can see here, is the tubes. The one in the left side is very turbid. It is because to increase triglycerides. Again, on the contrary, increased alcohol consumption and smoking are associated with decreased platelet activation. So these factors need to be considered before doing a platelet injection. And also another very important thing is the current health status of the patient. It is important that you understand that like if the patient is taking some of these medications that are listed here that causes or that can actually prevent the platelet activation process. So if it is important that this patient need to stop these medications 2 weeks prior and up to 4 weeks post PRP injection in order to have a good therapeutic outcome. But it is also important to consider what is the risk to benefit ratio here. If the patient is kind of having cardiovascular issues, if you stop those antiplatelet drugs, then is it really worth doing a PRP? So our patient with autoimmune diseases, is it worth doing a PRP? So you need to consider the risk to benefit ratio before approaching, before you actually go for the procedure. So again, in summary, here are the patient factors. Again, all these things can actually cause platelet premature activation, and again, you lose all those growth factors, and your PRP is pretty much empty shells without any growth factors. The next thing that can affect the patient outcomes, or the PRP outcomes, is the preparation methodology. As you know, there are a lot of different centrifuges out there in the market. Some people use a fixed rotor base, some use a bucket type. Again, the type of centrifuge can alter the outcome. Same thing with the rate of the spin. Your also can have a significant outcome in the type of PRP preparation. And finally, how you actually handle the blood during the blood draw. If there is a hemolysis happens, then there is a good chance that these red blood cells in the PRP can cause premature activation of these platelets, and you will actually lose all the growth factors. So coming back to the centrifugation efficiency, your first spin is really the most important thing in your in our PRP preparation methodology. See here, I'm going to give an example. There are 3 different spin rates that were chosen here. So the one in the spin rate 1, you can see there are like a lot of these platelets in the plasma fraction. That's exactly what you want, as compared to the one with the spin rate 3, where you lose a lot of platelets in the buffy core or in the RBC section. That means your recovery rate of platelets is significantly decreased. Again, as I earlier mentioned, the type of centrifuge and the speed is the one that alters the platelet recovery. Coming to the physicians, how physicians' decisions may impact the PRP outcome. The type of PRP, as it is well documented, that for joint injections, it is a leukocyte poor PRP is what is recommended. It is mainly because you're trying to decrease inflammation, and with decreased leukocytes, you tend to have leukocytes and less number of RBCs, which is also what you will achieve if you're doing like a plasma-based PRP injection. Then you'll have less amount of inflammation. So, and then with the buffy coat method, where you tend to have more RBCs and more leukocytes, it is mainly indicated for like tendon injuries, where there's already inflammation. It should not really matter if you actually include them. Sometimes some of these macrophages actually will help in the remodeling remodeling phase of your healing process. So it actually can help with this with PRP with leaching leukocytes. The dose of the PRP is a very, very important factor for you to consider. The PRP, I mean, the doses are classified as very high, high and medium and low. As you can know, the number of platelets means is the number of growth factors. That's an important thing to always consider. I want you to really focus on this study. If you look at here, there are like several of these studies shown here, that the one with PRP, the dose of 0.5 to 3 billion platelets, these studies are shown no significant outcomes with PRP therapy. However, the studies with platelets more than 3 billion showed a very significant PRP outcomes. So it is very important that you have at least 5 to 10 billion platelets, or 500 to 1,000 crore platelets per dose. It's not per ml or 5 ml or any ml. It is the total number of platelets. So in order to achieve this therapeutic dose, you need to have a starting volume of 40 to 60 ml of whole blood. Your baseline platelet count should be approximately, to minimum you start with 200,000 platelets per microliter, and your centrifugation efficiency should be at least 70% for optimal platelet dose that you want to achieve. And the type of anticoagulant uses, I know there are a lot of anticoagulants out there, but it is always the ACDA is kind of what is FDA approved, because it is already, it's well documented that it preserves platelet morphology much better, and also prevents activation, and it helps and prevents premature activation, and overall is considered a good anticoagulant. That's kind of what is recommended. Again, as compared to EDTA, it is something what I would recommend using for routine uses. The platelet activation process, this is something that is a very debatable topic, and every physician has their own way of doing things here. But again, you really don't need to activate those platelets, because the tissue factors will automatically activate these platelets, as shown in the data here. Even with activation and without activation, the amount of growth factors that are released is the same. So again, you need to understand why you're trying to do the activation process. And again, there is also another problem with activation, is you might actually denature those growth factors, because they're after all these proteins. So by activating, you might just lose the viability of these growth factors. So next very important aspect that you consider is what kind of procedure, what kind of practice that you use, landmark ultrasound guided injections. It is very well documented that the ultrasounded guided injection has very high accuracy of achieving the localization of this PRP as compared to the landmark based accuracy. So even though how much of experience you have, but based on the type of joint, as you can see here, there is a significant difference in your accuracy. Again, it is so important that you inject the PRP in the right location in order to have the maximum therapeutic outcome. And finally, again, it is also shown that the post-PRP rehabilitation process is very important, and you need to follow up with these guidelines, and then you follow up with the patient in 4 to 8 weeks and then see how the patient is doing. If the patient needs another dose of PRP, then you should go for it. Again, it depends upon the pain level at where the patient is. Again, you need to be the good assessment of this. So again, it's so important that the patient follow these guidelines in order to get maximum therapeutic outcome. So finally, I want to talk about these consensus statements here by European Society of Sports Traumatology and also American Medical Society for Sports Medicine. So they gave this position statement saying that there is a level 1 or grade 1 evidence that PRP is effective for osteoarthritis grade 1 to 3. But they said there is no adequate evidence for like grade 4 osteoarthritis, and it's also shown that PRP is a clinically better injectable option as compared to steroids. Again, as you can see, it is also shown that there are 2 to 4 injections per cycle of PRP treatment has provided better results as compared to only 1 injection. So I would recommend you to go through these consensus statements to better understand or have some more confidence in what you're doing. Finally, I made this short guide for physicians or physician scientists. So it is important to have adequate information about the patient before you approach the PRP. Again, I always recommend to take a baseline blood count so that you know how much of blood you need for this. And again, you need to consider the age of the patient, what kind of. Also, it's important to know what kind of grade you're dealing with, because I've seen reports of grade 4 patients being treated with PRP with not much effect, and they're saying that, oh, PRP doesn't work, but you need to know what grade this patient is in. Again, the type of injury also is important to understand. So finally, I would highly recommend to be completely informed about the patient, and so that you can have a better outcome by doing these PRP injections. Finally, I want to just quickly wrap this presentation by saying that there is actually the science behind how the PRP works. It just blocks the pro-inflammatory cytokines from binding to the chondrocytes, so thus prevent the chondrocyte degradation or breakdown. So it is a chondroprotectant, and it strengthens the extracellular matrix, increase the hyaluronic production from the synovium, and finally it helps in osteoblast proliferation by release of all these growth factors, and the PRP helps the process. So with that, I will take any questions through my email. You can reach me anytime, so I'll be happy to answer. Thank you.